and I hope to get to know all of you in due course. The first item on the agenda, apart from the voting, was the apologies for non-attendance.
Yes, Madam Chairman, we've had Naomi Eisenstad, David Watts, Joe Moore, Johnny Bugg, David Mayer, Deborah Needham and Toby Sanders. Okay, and I believe that Sean Silver is standing in for Joe Moore. I don't know about anybody else. Thank you very much. Do we have any notifications, requests to address the meeting? None received.
Thank you. Okay. Members' declarations of interest. Just remind you that you need to declare any non-statutory disclosable interest as an item comes up on the board. And if you do need to, you need to state the item number and the nature of the interest and whether it's disclosable, pecuniary or non-statutory. So next we move on to minutes from the previous meeting. Who's taken that? Somebody? Sorry, if I just do that. Minutes from the previous meeting, obviously I wasn't there, but is everyone happy with the minutes from that meeting on the 5th of December 2023? Seems a long while away now. Yeah. Can I have a proposer and a seconder for that, please? I can't.
Happy to propose.
Yeah. Would I see a seconder? Okay, Jane is seconded. Thank you very much. Okay. Next on the agenda is Chair's introduction, and just before I move on to that, I'd just like to say a big thank you to Councillor Helen Harrison for my predecessor in this role, and the large amount of work she's done, which I'm now discovering in my role. As for myself, I, as said, very new to this role, getting to know everybody and getting to know how the system works. So if you just bear with me, because I might not know your name. So it's, I know quite a few people in the room, but not everybody. Okay. So next we move on to the action log. We have items you'll see on the action log. The several of them, the first 4 there are completed, and they are, the first one is ending 04, data requested for environmental health, which was requested by the local area partnership in relation to air quality spikes, and that's now been received and shared with the board. And we also have we had a couple that were previously resolved before the last meeting as well. And then there was an amendment to the minutes, which has also been resolved. Okay. So the ones that are still in progress, there's for the Northants Health and Wellbeing Strategy, sponsors are being sought. Now, a couple of people have expressed an interest. David Mayer expressed an interest, and Jane Bethia will be the sponsor for tobacco, but it's an ongoing project, and we're looking for anyone else to put forward as a sponsor. I don't know if anyone wants to say anything on that at the moment, but if not, we'll move on. Okay. The next item is looking to bring the board development sessions to bring together organisations working in the 5 priority areas and how that fits with the statutory requirements. So that is ongoing, that will be looked into. There are a couple of other items that are complete. The school's support pack and other resources from the suicide aware strategy, and the suicide rate for 100,000 of the population to be shared with the board, the request of David Mayer. That's also complete. And Dr. Steve O'Brien from the University of Northampton requested 1 or 2 critical questions for his staff to help them focus on how to engage in and help develop the adult social care strategy. So I believe that's also complete. Okay. David Mayo was also going to share information on localised directory of services from the Foundation Trust KGH with Ali Gilbert to map the services available, and I've got that down as complete as well. Okay, so thank you very much for that. It's good to see so many items completed on the list. So now we move on to the Health and Wellbeing Strategy Update for tobacco, and I'd like to call on Chris Kenny to, is it Chris Kenny? Oh, sorry, Jane.
I'm just going to give a bit of a preamble, Councillor Mercer, if that's all right. I just wanted to remind the board of where we are with the health and wellbeing strategy and what we've agreed so far, because we don't see each other very often, so it's a really good idea just to update that. So what we've agreed as a board is to support the development of a strategy which is going to be an active strategy, which is about giving assurance, as we need to do, across 5 really important areas, but actually we're also going to be doing some work where we are identifying gaps. So it is very much that kind of active approach to a strategy. So just to remind us of our big 5, so the areas that we've agreed as a board are the areas of focus are smoking and vaping, and what Chris is going to do today is talk a little bit about where we are in terms of smoking and vaping, and then what we will be doing after this meeting is developing the action plan for the strategy, and that will come back in June, but I'll come back to that in a moment. We've got mental health and wellbeing, which nobody would disagree with, of course, as a huge area of focus. Children and young people, keeping active, and economic prosperity. And if you remember, colleagues, these all align very closely to the Live Your Best Life ambitions. So we're not duplicating anything here. We're very much aligned to the other strategic areas across the patch. But really what we want to do is look at what else could we be doing as an economy and as a system in these really important areas of focus. So we want to do a strategy that's live. We want it to be responsive, so if some things happen, we can think about doing different things. And we want to actively engage communities in this strategy, which is why we're going to try and align it so closely to the local area partnership programme, because that is an extremely important vehicle for us to do that. What we've been doing in the background since you last saw us is we've developed the work around smoking and vaping, and we've been starting the work on the other areas of the strategy so we can bring that to the board for an ongoing update and for some discussion. But we've also been looking for other areas who are taking a similar approach to a really active health and wellbeing strategy. And we're actually buddying with the place-based partnership in Nottingham. So Nottingham are taking an approach which is very much around how do we work as a system to see active change around the things that we really want to see change in. So what they have done is they've given us some information on how do we set up the processes and the governance so we can show that change and we can be active, and also how do we make sure that we are really getting the right process in place, because as we all know, if you don't have the right process in place behind a strategy, it is a document that sits on a shelf and doesn't necessarily bring the change that we want to see. So a couple of things that we've worked on with them is around how do we get the best challenge but also the best movement in what we want to do. So you remember, colleagues, at our last meeting we talked about a structure where we would have an executive sponsor at board for each of these areas. So I'm going to be the tobacco, smoking and vaping executive sponsor. And then what we'll have alongside that is we will have some programme and project management that we'll provide through public health so that we can really make sure that's very active and moving, but also that we're going to be pulling on the assets we've already got as a system. So if we think about smoking and vaping, we have a very active tobacco alliance already. Why would we not use that to really inform this area of the strategy and to be essentially part of the home of this element of the strategy when we've got that in place? The same for mental health and wellbeing. There's an amazing, I've started going to the mental health collaborative meetings that are run with support from the ICB. Fantastic opportunity to link what we want to do with the priorities and the work that's coming out of that collaborative. So we're using that existing infrastructure to really make sure we've got the right approach. The other thing we're going to be doing is making sure that we bring to this board all of the action plan so we know what we're doing, but we also bring to this board where we are finding issues where we're getting stuck. So, for example, if in the smoking and vaping area we find we're getting stuck in a particular area, as a board we all have a role in thinking, well, what's my organisation's role of unsticking that? So this will be an ongoing process and interaction with this board about how we bring that health and wellbeing strategy to life, how we resolve problems, and then, of course, how we track the progress and change that comes about from this particular way that we're linking work in. And I don't want to steal Chris's thunder because he's done a huge amount of work on the smoking and vaping one, but just to give a little example, oh, I can hear myself, a little bit of an example of how we want to work differently, is that we have the local area partnerships. What a fantastic potential vehicle we have there for bringing change at community level. So from a smoking and vaping perspective, we know that Corby has really high levels of smoking. We know that in some of our communities in Corby, 1 in 3 adults still smoke, which is much, much higher than the national average and much higher than the average for North Northants overall. So clearly, we're not doing something right. We haven't got something right for this particular group of people. What we feel we could do differently is work with the community to try and address, well, what else could we be doing? Is there a different way of providing this service? Is there a different way of providing information? Is there something else we could do? And we'll use the local area partnerships as a vehicle to help us do that community engagement and to try things out. Because if we don't try things out, we will never achieve a difference and make that change that we want to see. So I hope I haven't stolen too much of your thunder, Chris. But I'll pass over to you to go through the smoking and vaping work. Thank you.
Thanks very much, Jane. Yes, I'm just going to do a brief summary of the paper, which I hope people have had a chance to read through. I'm going to make some salient points, summarise with the recommendations at the end, Chair, and then happy to answer any questions on any aspect of the paper at the end. Okay, just to reiterate how important tobacco is as a public health issue. It is, without doubt, the single most important preventable cause of ill health in this country. It causes significant amounts of mortality and morbidity. For example, it causes 25 to 30% of all cancers in this country, 90% of all lung cancer, and causes about 90% of all cases of chronic obstructive pulmonary disease, which causes significant morbidity for people who have difficulty breathing. So there's no doubt that it's a significant problem. In addition, about 11% of all mums who deliver are still smoking at the time of delivery. As Jane said, there are, even though about 15% of the whole population of North Northants smoke, some parts of the district, it's 1 in 3, about 30% or even more in some pockets. So even though we've done a lot about trying to get people to stop smoking over the years, there's still about 50,000 people across North Northants who still smoke. So it's still a big issue. Next point I want to make is about how important the vaping issue is. There's a section in the report about vaping. I don't want to go on about it too much, but suffice to say that if you want to give up smoking, vaping is a useful therapeutic modality to help you give up smoking. If you don't smoke, don't vape. I think that's one of the sort of biggest things we need to say. It's helpful for smokers, but if you don't smoke, please don't vape. The next thing I want to say is about the smoking cessation services locally. We have some well-tested and tried services within the local authority, and there are some NHS services which work in a very complementary way, some specialist services for people with, say, severe mental illness or pregnancy, for example. They do work well, but they are under severe pressure, which is a good thing because lots more people are wanting to come into those services to actually give up. So one of the things that we're going to be trying to do, and I'll come on to it in a minute, is increase the amount of smoking cessation resource there is in the system to cope with the additional burden on the service at the moment. Just a quick word about tobacco enforcement. You'll see in the paper there's a lot of work going on via the trading standards arm of the local authority. They do some superb work in tackling the illegality of illegal tobacco coming into the district and ensuring that retailers are working within the boundaries of what is lawful in this country. We have put some money from the public health grant into that, so it isn't just about smoking cessation that the public health grant funds. We do put some money into trying to address the issue of illegal tobacco. Just a few words about the national strategy. People will have heard, I think we talked about it at the last meeting, the announcement that the government made back in October, I think it was, trying to develop a smoke-free generation, which is subject to parliamentary agreement. There's going to be a lot of work done on trying to address the age limit at which people can buy cigarettes, and also addressing the issue of how easy it is to buy vapes and how attractive they are, particularly to young people. There's a lot we can do on that, and I'm sure we'll come back to that when we talk about the action plan next time, Jane. But one of the issues within the national strategy is some extra resource, and you'll see from the paper in the region of £487,000, I think it is, that's been allocated to Northants. And this is a golden opportunity for us to, A, increase the capacity within the smoking cessation services, and as you'll see, some of the main ways in which we intend to spend or suggest spending the money is A, on staff, but B, on things like nicotine replacement therapy and other therapeutic modalities to help people give up. But one of the things we do want to do is to be a little bit more innovative, think a little bit more laterally about where the smoking cessation services could be, and the local area partnerships that I'm sure we'll come on to a bit later are, almost certainly a really good vehicle for helping people in local areas give up smoking. We're working with the NHS in terms of some of the specialist services, and our suggestions at the moment are that we focus on people with routine and manual occupations we know where the smoking levels are higher than normal, and also pregnant mums where we know smoking has a severe impact on both the mum and the new babe. Longer term, we can actually have a system where we can address some other issues, for example, mental illness in our specialised services. The last thing I want to say is about really sort of all partners ramping up their sort of support for smoking and the tobacco agenda. And two of the appendices with this report are about pledges for both the NHS and local government to say, we really support the whole issue of non-smoking now, and we're going to do as much as we can about it as part of the Health and Wellbeing Board agenda. I'm not suggesting we automatically do those. They're there for discussion. Some of the local authorities and some NHS organisations have signed the pledge, and it is an opportunity for us to discuss whether that's a useful thing to do. So finally, Chair, just to sort of note the recommendations from this report, if we can please note the contents and the importance of tobacco as a public health issue, to note the current nature and impact of stop smoking services locally, but acknowledge the fact that at least 50,000 people are still in Northern Northants smoking. To note the opportunities that local area partnerships will bring to being a little bit more innovative in the way in which we try and address the problem. Certainly to ask the Northamptonshire Tobacco Alliance to actually coordinate things on our behalf. As Jane says, there's no point in us setting up a new infrastructure. The Tobacco Alliance is there across the whole county, and they will be in a very good position to coordinate this on our behalf. To support the proposed development of stop smoking services with a focus on the issues I've just been talking about, pregnant mums, routine manual workers, and a focus on people most in need rather than just a first-come, first-served system. To endorse the draft proposals that I just mentioned about spending the new money, the £487,000, and if we can consider whether the declaration on tobacco and the smoke-free pledge are things that we could usefully do at local level. So at that point I'll stop, Chair, and hope that's helpful, and happy to answer any questions.
Yeah. First of all, have Jane Bethia.
Thank you. Thanks, Councillor Mercer. So I just wanted to remind the board of what happens next. So we've agreed that smoking and vaping are one of our areas of priority. What we're proposing to do in the time between now and the next board meeting is to do some engagement work and some work with you as individual members to develop the action plan, which will say this is the action plan that we own as a health and wellbeing board to help us see the change we want to see in relation to smoking and vaping. And then we will present that at the June board. At the same time, we also then move on to keeping active as our next area of focus. So you can see that we iteratively move on from meeting to meeting. So we have a set of action plans which will start working as soon as they're agreed. So we will be working this year on it. but it will be an iterative process over the rest of this year so that we can agree our key areas of focus. Where we're going to have more work to do, colleagues, I think is particularly in relation to children and young people. We want to make sure we get a really good focused area that we want to focus on as a board, that we feel that we can do something around, and also mental health and well-being, because that's also very broad, and what we want to do is say, well, what is the focus of that going to be? So part of my reason for sort of talking about this again is that you will be hearing from us as individual board members to have some discussion about all of these issues as we go through this process. The other thing you'll all get at the next meeting is my love for process. I love process, and I'm not going to be shy about it. So at the next meeting, when you see the action plans, we will also present all of the ways by which we are showing and talking about the areas of challenge, how we're going to do highlight reports, how we're going to do reporting, to make sure we've got a really strong governance around that, the action plans and the ways of working. So we'll bring that to the next meeting as a suite of documents for you to all have a look at, as well as to talk about the action plan and our next stage of talking about keeping active.
Thank you very much, Jane, and I hope everyone's happy with that. I first have Councillor Nick who wished to speak.
Yes. Thank you. Thanks for your report. I have 2 points of clarification and then 1 question. The first point of clarification I have is that you mentioned that around 42,000 houses live in poverty as a result of their expenditure on tobacco. Now, you mentioned the average yearly expenditure is around £3,000. Are you saying that without that expenditure, they wouldn't be living in poverty? Is that what you're saying there? So on the report, pardon?
So, can you just say that again?
Yeah, so on the report you mentioned 41,750 houses are living in poverty due to their expenditure on tobacco. Does that mean if they didn't spend that money on tobacco, they wouldn't be living in poverty?
That's one of the issues, yes.
Yeah,
I mean,
okay.
I think the point we're making is that spend on tobacco is considerable. If you're smoking 20, 30, 40 a day, I mean, I've forgotten the exact price of a 20 cigarettes, but it is a considerable amount. So if you give tobacco up, then you've got that money to spend on other things, food, clothing, what have you. So it does help the sort of poverty gap, yes.
Yeah, and then my second clarification is, you mentioned about 50% of people now experiment with vaping. And when you say experiment, how often? Is that just doing it once, or is that... What's the regularity of experimenting?
I think that's at the point at which the survey is done. I think it's have you ever
just ever
experiment? Yes, I think it's ever, because most of the surveys are done on teenagers and young people.
Yeah.
So it's have you ever done that? Yeah.
And then the last one is, you mentioned that if you don't smoke, vaping is much safer, and if you don't smoke, don't vape at all. And I completely agree with the messaging. I would say that the one problem that I feel like a lot of young people looking at this will see is that they read that and all they get from that is vaping is safe, right? Would you agree that a lot of the problems we have to challenge is the discourse? People, when you ask young people why they vape, they say, well, it's safer, it's much better than smoking tobacco. Would you agree that challenging the discourse and the misinterpretation of that is one of our biggest challenges?
It's exactly one of the challenges, yes, because if people are considering, do I want to smoke? Oh, I'll just vape because it's safer. Yeah. That is part of the problem. That's part of the problem.
No, I agree.
Because vaping isn't 100% safe in its own right.
Yeah.
So we shouldn't be advocating vaping if you're not already smoking. Yeah. That's the message.
So do you think going forward, when we use phrases like vaping is safer, we should be like it's less of risk? You're less likely.
Yes, and I think the messaging around vaping is something that both at national level and at local level we need to address quite quickly, because the point that you're making is one that if people get the wrong message, then they'll do the wrong thing.
Because that's what they're going to read, right? They see vaping and safe in the same, right next to each other, and they're going to assume that.
I see what you mean.
Yeah.
Yes,
Yeah. Thank you.
Yeah, good point. Thank you.
I've just got Jane to come into that.
I just wanted to also pick up on that, actually, Councillor Nichols. It's really important, and something that really struck me. I was at the Big 50 event recently in Northants, and met a fantastic group of young people from Tresham College, and one of the young people stood up to speak about vaping. and saying, why is it I'm seeing year sevens in, and people like that, walking around the towns to vaping? This is something that it seems to be a really fairly recent phenomena. And he was vehemently against it, which I thought was really interesting. So one of the things we will be doing as part of this work is some engagement work with our young people locally. What we really want to do is say, what is the right thing to do for young people? So what is the information that is needed to help people make that informed choice? Because, we're seeing a lot of young people vaping. We certainly do not want them to be vaping. We do not want them to be vaping. So how do we work with young people to get that messaging right, I think is really, really important. And how do we use young people as champions and advocates for that, I think is really important. I think the other thing is that I just always remember the CMO. So Professor Sir Chris Whitty, will say, if you smoke, then vaping will be less harmful. If you don't smoke, don't vape. And I think if we can just really get that really cemented into people's minds, we'll be in a far better place. But this is the beginning of that work, I feel, particularly about getting, as you said, the discourse right.
Yes, I was at that Big 50 as well, and it was very, very powerful. This young man was really passionate, I thought somebody like that would be a really good champion for this process. So I've got Kate.
Yeah, thank you. I totally agree. I think we should do a piece of work around a youth-led project on vaping. It'd be great to get their perspective because, just understanding that chat and conversation and motivation is really crucial rather than coming in with a big sort of pointing out why they shouldn't be doing it. But I was just going to ask about how you see this layering onto the CWFs, and actually, because it's quite a good example of something that we could roll out to CWFs, because I think we are moving into a phase where we do want to get into some doing at CWFs, and this for me is quite a key sort of, especially chairing the Corby Community Wellbeing Forum. How do you see that sort of working?
So my view on that one is the more we could get people involved, the better, actually, Kate. So it would be a case that we'd see the community wellbeing forums and the LAPs working with us on that. The most important thing for us is that we get the voice of the community to help us find the solution. And I think the community wellbeing forums and the local area partnerships feel a really good place for that conversation to start. And I've had some early conversations with, particularly in Corby, people who work in different sort of voluntary community sector organisations in Corby. There's a really amazing wealth here of people who can help us get to the right solution. So how we work with yourselves, how we work with the local area partnerships, we're up for anything, Kate, I think is ultimately what we're saying on that, because we do need to get this right.
No, that's great. And I think it's just layering it into that structure so that it's the strategic conversation at the CWFs, and it's thinking about partners and how they carry that message down. And then at the LAP, it's that community engagement. But it strikes me as quite a good one that we could actually really test at CWFs.
I agree. I think particularly with the Corby CWF and LAP, as we've seen in the report, that it's around 30% in Corby smoking. So that's obviously a good starting point. And just going back to the cost, £3,000 per person on average annual, that's an awful lot of money. It all seems to me that you're just rolling up a £5 note and just setting fire to it myself. But
that's one way of putting it, Chair. Yes.
Yes, Ali.
Thank you, Chair. Just building on the CWF conversation, you're absolutely right, Kate. And Jane and I have had conversations after we met with Nottinghamshire in terms of best practice. We need to get the governance right on this and make sure that we're linking the programme of work around the health and wellbeing strategy with the place work and through the place board to make sure that it's all joined, we're not duplicating, and we understand, as you say, the layering about who's doing what and connecting it back through to the programme. So we've got some proposals around that, Kate.
Thank you. Do we have anyone else wishing to speak? Oh, yes, sorry, Dr. Pogge.
Yeah, it's just something that leaves me a little bit uncomfortable. The suggestion, vaping, if you rate the smoking, better vaping. We don't know what we don't know. And, unless there is proper evidence that it's not going to make a worse damage than the tobacco, we haven't got enough time behind us to confirm that. And I know because even recently I had discussion with patients and saying, oh, you shouldn't really smoke vape, and he was saying, oh, I thought it was better. It's chemical going into the lungs, so something that tells me, make me feel uncomfortable.
Yeah.
I think the evidence so far that we are aware of is that vaping can be a useful therapeutic mode to get people off smoking. That is the evidence that we know at the moment. You're quite right. I mean, there's research being done all the time, and over the next few years we will find out more about what the consequences are. But as we know it at the moment, vaping helps people get off smoking, and smoking is more dangerous for you than vaping.
Have Gabriella.
I just sort of on the same point as well. I think there could be a lot of success when we're trying to build a campaign to encourage young people not to vape by maybe looking at some of the chemicals that the vapes produce and sort of looking at those negatives and trying to just emphasize that it is, although you don't want to take away from the fact of those who are going from smoking to vaping, to not to use that as a successful tool to then go off of smoking completely. I think there's a lot to be done around highlighting some of those chemicals and maybe the negative effects. I know that there's no long-term sort of science-based evidence to really prove the sort of negative implications of vaping, but possibly there's something as well when we're looking at the monetary spending of young people. Although vaping is a cheaper option than smoking cigarettes, it still is quite a bit of money to spend, especially for a young person. And if there's a way to highlight maybe just the impact of saving £6 a week, what could they do with that? If there was some sort of way to positively spin that, I think that there could be quite maybe a success with young people, because I think it's just about trying to scare them a little bit, but also show them the positives of being able to stop.
Okay, Jane.
I would agree that there's the financial side of it. We also have to be mindful that the parents are buying children vapes. Yeah. And we have to make sure that any education, information and work we do is also aimed at parents, which is why we want to work with the family hubs and work slightly differently around that, because we are finding that, reports of people saying, well, I know that my child is vaping, so I'm buying them vapes. So that is an issue that we also have to deal with. And also just to pick up on about vaping and smoking cessation, vaping isn't the only thing we offer as part of smoking cessation. We offer a whole range of different things, nicotine replacement therapy. Some people just want to do it with the support and without any sort of additional thing. Vaping is one element of smoking cessation, it's not all of it. And for some people, it is the thing that helps them stop smoking. So we have to see that in the round in terms of the wider smoking cessation offer. And we also have to work with what's given to us as guidance nationally around what is the best use of resources and what the evidence base says. So I think we are doing that, but we are very open. My position in terms of vaping is to be neutral. My position is to be evidence-based and to look what the evidence is telling me. And so what the evidence is telling me at the moment is that there is a worrying number of young people starting vaping, and we want to do something different to stop that. So I think if we can work as an economy to really help young people to avoid that, that would be really, really helpful.
Yes, sorry. I didn't know.
Yeah, so notwithstanding the panoply of interventions that you've got in terms of smoking cessation, I'd written down one key word, and that's why. So, if there is resource available, and we know, because my daughters work in schools, and it's one of the biggest challenges they've got on a daily basis, is trying to manage that. We need to be asking the question why. Why is it that children are doing this? What research have we got? Is there something we can do locally? And in particular, in Corby, if the figures which have been presented today are correct, so I have no doubt that they are. Why is it that Corby has this particular issue in say, comparison to Kettering or Wellingborough or somewhere else? They're really important questions that we need to ask, and I think that probably needs to be incorporated into the action plan. And the second point I'd make is, in terms of how organisations can actually support and help with this, I think it'd be really good to identify where those organisations sit within the action plan. So are there particular things that particular organisations can do to help in terms of tackling the problem?
Thank you. I think one of the big issues is that these vapes are so prominent in the shops, and previously the cigarettes have been put back out of sight, and the vapes are colourful. Apparently, I don't know this from personal experience, but taste like sweets and things like that. So that is the problem, is of young people vaping who've never smoked, who are not using it for cessation of smoking. Kate?
Yeah, really quickly, but just to say that I just Googled it actually, 5 million vapes are disposed of every week. So the environmental impact, and that may be an approach to come out from with young people as well, but that is seismic, isn't it?
That's incredible, yeah. Did you want to come out?
I just actually, suddenly, Kate, when you said that, I thought, actually, our young people really do care about these issues around sustainability and climate change, and it's really important that we actually share that with them as part of this work. So thank you for that, Kate.
Okay.
And as Jane said, that she will be in touch with people individually to actually see how each individual organisation can contribute to this and where they fit in. So I think that will be very good to see on the action log for the next meeting. Okay. Any other people wish to speak? So if we can then move on to the recommendations, which are on page 18. Chris read them all out, so I won't bother to read them out. But is everyone happy with all of those, including signing the pledges that were in the appendices as well? If everyone's happy with it, could I have a proposer for that? Councillor Nicholl propose and seconder. Didn't anyone else like to? Scott. Okay, thank you. So if all those in favour of that, everyone happy to support those recommendations? I'd like to indicate. Okay. I can't see many hands up, so it's just me. Is everyone in favour of those? Yeah. Is anyone against? Let's put it that way. No. Okay. Thank you very much. Okay, so we'll move on to the next item, which is a combating drugs partnership. And I'd like to hand over to Jane to introduce that.
Thank you, Chair. So I'm the current chair of the Combating Drugs and Alcohol Partnership. So we've put the word alcohol in there because lots of people will be aware that alcohol is extremely harmful. There's many harms that come from alcohol as well as drugs, and we need to really recognise that. And alcohol can be something that people don't know that they're drinking to an extent that's harming their health. So I've taken over recently from Sally Burns. This is a cross North and West initiative, the Combating Drugs Partnership, and it comes from the Harm to Hope strategy, which is a national strategy that was finished in 2021 and gives some direction for us as an economy of the things that we really, really want to focus on around improving people's health and well-being in relation to drugs and alcohol. So there's three key areas, and the paper today is largely focusing on the world-class treatment and recovery system area. But the three key areas of From Harm to Hope and what we're doing locally, one is about breaking drug supply chains. And so you can imagine from that the partnership itself is extremely broad. So we have a number of people, organisations on that partnership, and we partner very closely with the police. And the police are extremely active in this area and have been incredibly supportive. Lee McBride is, for example, leading that particular element of our strategic approach. The delivering world-class treatment and recovery is something that is largely about how do we get more people into treatment and into that recovery journey. Now, that's always been a particular issue for every area, is that you will always find people who are resistant to treatment. And what we have to also recognise is that for some people, their first go at treatment isn't right, and they have to come around that cycle a few times. But what's really, really important for us in North Northampton, across the whole of Northamptonshire,
is that we offer the right services at the right time that meet the needs of individual people. So we have a really big focus in that partnership on that element, and that's largely what I'm going to focus on today. Although what I would like to say at this point is a huge thank you to so many different agencies that are involved in this. Our cross-work between public health, for example, and the police has brought such enormous benefits to individuals in the last 6 months that I've seen, including, for example, information being shared very rapidly about a drug that is causing concern, and the police being there to support that and leading to almost immediate arrest. It's been a really fantastic partnership, and we're really very, very pleased with how that's going. So the key things I wanted to pick up today are the priorities that we have, particularly around the element of the partnership that's around making sure we have the best treatment offer. So one thing that we're doing very closely is monitoring how many people we have in treatment. So that's about getting the right data to say, okay, across this patch, who is coming into treatment? What are their outcomes? So how many people are dropping out? How many people are completing the treatment successfully? How many people are coming back through the process? Because it's important that we get that. But it's really important as well that we look at equity. So that we look at, for example, is it that our services seem to be overrepresented in terms of white men of a certain age? We need to make sure we've got that lens of equity all the time. So we're doing a lot of work to say, who are we seeing in treatment? Are we actually missing people in the population? What could we do differently to make sure we get everybody who has the capacity to benefit from this treatment through that treatment process? And that's been a really big focus of what we're doing. We're also looking at how do we do things a bit differently where we've got particular areas of need. So during COVID, for example, during COVID-19 response, I was responsible for people who are in vulnerable settings, not in this area, in a different area of the country. And what amazed me is how vulnerable some women are. So there were some women, particularly women who survived through sex work, are extremely vulnerable. And what we need to make sure is that we have the services in place that are really accessible. And these probably need to be more outreach focused, they need to be based on trust, they need to be different to get people who are extraordinarily vulnerable into a treatment service, into a service where they're being screened for bloodborne viruses, into a service where they could probably then access that information they need to move on into different parts of their lives. And that's something that we're trialling at the moment, again, learning from other areas in the country that have got some particular expertise on that. The other area that is really important is continuity of care, and I know that anybody here who's either worked in criminal justice or has experience of that in any way will know that a really important thing is that when people leave the criminal justice system, it's essential that we pick them up into the right services very quickly, because people can go the wrong way very quickly. And so a piece of work that we're doing locally is to say, how do we most effectively work with our local prisons, for example, to make sure we get continuity of care through that gate so that people go into community services and can start that recovery process as they come out into the community in a really positive way. This is much harder than it looks sometimes, and there's lots of work that needs to do to build relationships with different organisations, but certainly a big focus of what is happening through the Crime, Drugs and Alcohol Partnership is that piece on continuity of care. The other piece that we're doing and jointly, and there's some fantastic work going on across the area, is around what we used to call dual diagnosis. So that's what it used to be called. Now we call it coexisting substance use and mental health issues. But lots of people here will completely understand that if you've got somebody with a very significant mental health issue, it's really important that you deal with that at the same time that you look at someone's recovery from substance use. If you don't get that right, and you don't do that in a joined-up way, you can really hamper someone's recovery from substance use issues and also their recovery and progress in terms of their mental health. And so there's some really interesting work going on locally about cross-working. How do we make sure that the substance use services that sit in the third sector, actually in the main in Northamptonshire, how do we ensure that they are working hand in glove with other agencies like NHFT and like other parts of the system, primary care, for example, so that we do have a really good offer around people who have significant mental health needs? And that is very common. That's one thing we have to remember, particularly people with very entrenched substance use issues, it's very common to have a very significant mental health issue as well. It's also very common to have a whole range of other complexities. And so it's never a case that we should be just looking at substance use. There's nearly always something else going on. In terms of recovery, we're looking at national grant funding to increase rehab places that are available. And I've mentioned that dual diagnosis or coexisting model to make sure we get that right. The other two areas I wanted to mention, which I think has been amazing work locally, actually, again, jointly with a whole range of agencies, so our drug services locally, but also with the police and other agencies, including Kettering General Hospital and NHFT, is the work that we're doing around the local drug information system, which is called LDIS, and also drug-related deaths. So the LDIS system is that system that we will get quite often a service user. Some of our best information comes from service users. Service users will raise that they have taken a substance that they expected to be X, but the response they got to that was very much Y. And that's really worrying, because what we're always trying to keep an eye on is there something in the market that actually is going to really harm people because it's not what they think they're taking. So we have this local drug information service that's actually run through public health, but with incredible support across the board, and that is very, very busy indeed, and is really impacting on our intelligence around what's around in the local system. And that's really important if we want to make sure we minimise harm and we do the right thing. The drug-related deaths is very important for us to consider as well. We should be learning from every drug-related death. We should be looking at that and saying, what has happened? Why has this person fallen through the net? What else could have happened, and what can we do to make sure that we reduce our number of deaths? Particularly, there's a focus on people who've been in treatment, who then die through a drug-related it's drug-related issue. But we also want to make that slightly broader so that we're learning all the time. When somebody tragically dies from a cause linked to their substance use, can we make sure we're putting the right things in place in terms of really having the right response locally? So we have our meetings on a quarterly basis, and they are very much focused around how we're going to meet some of these challenges. It's also an opportunity for people to share areas of good practice, but it's an opportunity to share areas where we're stuck, a little bit like what we described earlier in terms of this board. And it seems to be working really well. If people are interested in becoming more involved, we're open to people in being involved with the Combating Drugs and Alcohol Partnership, and we're always looking for new ideas and new things that we could do. So I just wanted to give that brief update, Chair, and also just to thank the many, many organisations that have shown such great work in relation to this, because I do feel we've done some fantastic work, particularly around sharing information, making sure we're getting the most vulnerable people in a less harmful situation, and that feels like we're moving in a really positive direction.
Thank you very much, Jane. Pratima, let's see.
Jane, thanks for that. And what was the DAT, wasn't it, in the previous guys, is this new partnership, isn't it? Or is it different?
The DAT's quite an old concept, Pratima. Sure. So possibly this is more of a cross-system way of addressing the issues raised through the national strategy. Okay. So in a kind of way, yes, but it's very multi-sectorial. It's very, very much a kind of how do we help each other type approach. I'm finding it really helpful because it does feel quite action-focused.
Yeah, I was just going to say the Wellingborough Lab has identified substance misuse, I think you know that, as a key priority. And when the lab coordinator brought the primarily third sector organisations, which are very kind of embedded in this work and have been for a long time, it may have been possibly the first time they've come together in a locality as opposed to be county-wide kind of functions and commissioned services. So there's some potential for a community-led approach where the providers are actively involved and are the specialists for doing this kind of work. So there's real potential for kind of drilling down and seeing what solutions they can find as well. And I really welcome the simple, cohesive referral system kind of as a goal because, again, I think that group actually found that sense of communities don't know what's available. And it's one of the actions that they're going to take about making sure there's a cohesive message around who the services are, how to get to them. And I think the female-only referral service is really, really important here as well.
Thank you. Yes, Jane.
And thank you for raising, Pratima, about the Wellingborough LAP identifying substance use, because this is how this should be working. It should be that a local area partnership or, you know, says actually this is an area that as a community we're worried about, and then we respond. I think that is where that sort of power of the community work comes into this new way of working. And what I would suggest that we have a conversation about what could we do differently around Wellingborough with the resources that we have. I'm responsible for the drug and alcohol services in this patch. We should be working in that way, that we look at different approaches to meet the needs of the community. So we'll also have a conversation outside of here, if that's okay.
Yes, and I would also commend we had a health scrutiny meeting about a week ago, which is on video on YouTube, and we had some excellent speakers from the services that help with the recovery, and they all explained how they work and what process they go through. So it really, and they had some service users with them as well. So it was, you know, really interesting to see what help there is out there. So I think that might help the LAP as well. If you watch that, I think it'd be quite useful, and then maybe engage with some of those services. Anyone else wish to comment on it? We've been asked to note the report, so I can't see any hands. So thank you very much, Jane. And the partnership is, you know, it's really interesting. I've been to the board meetings and, you know, all trying to achieve things by working together. So thank you very much. Okay. Next item on the agenda, find the right page, is the James Willis, who's doing a presentation for us on Northamptonshire Police Right Care. Thank you very much.
Good afternoon, everyone. So my name's James Willis, and I'm Chief Inspector with Northamptonshire Police. My day job is looking after the Control Room Inquiries Department, but I'm also tactical lead for the introduction of Right Care, Right Person. There are some slides. I don't know if anybody's able to share them on the overhead screen. If not, it doesn't matter. Yeah, they're in the pack, so feel free to follow through as I go along. So Right Care, Right Person is a concept that was trailblazed by Humberside a couple of years ago and announced with much fanfare, whereby they recognised that the majority of their calls for service were in fact picking up demand for other agencies such as health and social services. So they took the decision that they were going to, on a specified date, start saying no to all those calls for service. And they announced some amazing results as a result. Now, this was picked up by the College of Policing and the Home Office and the National Police Chiefs Council. Anybody really in a position of authority that's got any sway or direction as to where the police service nationally goes. And they've mandated and supported it and encouraged all forces to pick it up and run with it. It really took off, I suppose, in the public consciousness when the Metropolitan Police went live with it in November. Before then, it hadn't really been probably talked about that much in the public sphere. So what I'm going to talk about is our introduction of it in July, what it is, how we introduced it, the partnership involvement, the data, and some of the interim results and the next steps. And it sounds like quite a lot, but it's quite a short presentation. So we introduced it on the 1st of July, and it's basically an enhancement to our current welfare check policy. All of our key strategic partners were briefed on the changes before we went live, and it's based around the concept that the College of Policing authorised professional practice advocates that the police should not assume, either directly or indirectly, responsibility for all forms of risk. They may have no legal right or power to do so and could compromise their reputation by exceeding their role. Other agencies may have more appropriate skills in risk assessments, resources and legal powers. And ultimately that being helpful may create other risks for the police. So the kind of rider to that is that protecting vulnerable people and keeping them safe is and will remain a priority for Northamptonshire Police. And the force would never knowingly make a decision about its resources that would put anybody in danger. That said, we're not always the right people to go. So the policy really is about making clear where and when we'll say no, making that clear to other agencies, to the public and to our staff, and reassuring our staff that they've got the backing of the organisation when they do that, and also to avoid risk-averse decision-making. So just moving on to the second of the slides in the pack, there's a couple of really important definitions within the policy, and that's the first one is around a welfare check. These are really the two key things in there. And the definition of a welfare check is a request from an external agency to check on the welfare of an individual who they deem to be vulnerable for the purpose of reporting back to the agency that they're safe and well. And the definition of an external agency is any agency other than the police, but it doesn't, and this is really important, it doesn't include a friend, a relative, or a member of the public, or anybody from their work. So we will still respond to we will respond to requests from agencies to conduct welfare checks on people only when a threshold is met. And that threshold is quite a high one. It's when there's an immediate risk to the life of that individual or an immediate risk of serious harm to an identified person. And if it doesn't meet that threshold, then we'll be pushing that back to the external agency and asking them to consider other means of managing that risk and that demand. And just because, and it sounds harsh, but the legal advice is really clear on this. Just because an external agency doesn't have the capacity to meet its own demand, that doesn't then make it the responsibility of the police service to pick that up. So I think it's the third slide now, because I'm doing it from some notes. Mental health is probably our biggest right care, right person challenge, and we've got some specific sections around there in the right care, right person policy. In particular, we won't look to deal with people who have failed to return to a mental health institution from voluntary leave, nor will we generally go checking on people who've left institutions to which they were voluntarily admitted, unless it meets that immediate risk criteria. The assumption is if they were deemed well enough to be given leave or well enough not to be detained by force, then they are sufficiently in charge of their own destiny and don't require any police intervention in that respect. Notwithstanding that, there may be occasions, and there very often are occasions, where we feel it's appropriate to treat the patient who's gone missing as a missing person, in which case our missing person policy would apply. So the two do run alongside each other, and they have enormous overlaps as well. So just because somebody has not returned or they've walked off doesn't mean the police will wash their hands completely. That will be subject to a risk assessment and a careful look at the definitions and the individual circumstances. Where agencies are requesting assistance and we're declining it, there's a really quick means of that being resolved internally, and it just simply gets referred, escalated up in the control room to the force incident manager, who's the inspector in charge of the force, and if need be, they can contact the duty superintendent, the duty officer, and they will make that final decision on whether or not we're going to respond to that call for assistance or not. Just to emphasise really that a different approach is taken to calls from members of the public who may have concerns for an individual. They may not be able to act on those concerns, and indeed they don't really hold any responsibility for that individual from a legal or potentially moral standpoint. We will continue to deal with any calls from members of the public, workplaces, etc., using what we call our Thrive assessment, which looks at the threat, the harm, the risk, the vulnerability, and so on, to make a risk assessment, and we will respond appropriately. It doesn't necessarily mean we'll always respond, but we'll respond appropriately. That may mean signposting people to a more appropriate agency if it's appropriate to do so, or it may mean responding ourselves, as we always would do, or always historically did. So in terms of when we introduced this, as I said in the opening in my opening, we introduced it formally in its entirety across the county on the 1st of July. But we already had a very robust welfare check policy in place with some really strong, mature and responsive partnerships. So this was never going to be the kind of sea change for the county that it was in some places like Humberside and other areas of the country. We took our own legal advice before launching it rather than waiting for anything centrally from the College of Policing. We trained our key staff, in particular in the control rooms and the contact centre. We briefed our strategic partners and asked them to cascade this. We issued a press release and we've established a performance framework in order to monitor the impact of this policy, most of which drew on existing information that we already collated. So to kind of summarise it, we almost had right care, right person in all but name, certainly in practice, before this was officially adopted and introduced. And we tried to keep it as simple as possible. Fortunately, we didn't need to bog ourselves down and delay things by building partnerships because they were already in place. So, in terms of partnership oversight, notwithstanding that we went live with this on the 1st of July, there was obviously going to be recognition that the application of right care, right person would expose or exacerbate some gaps in provision, and that this may result in some risk to the public. So to close those gaps, a collaborative approach was always going to be required. To this end, North Hampshire Police, our partners under the auspices of the County Integrated Commissioning Board have established a Right Care, Right Person Gold Group, known as the Core Group. The co-chairs are drawn from the county's ICB. It's partnership-led, not police-led, and the membership consists of senior strategic partners from the ICB, EMAS, Mental Health Services, Children's Services, the NHS, Fire Rescue, DWP and others. And they've broken the strategic objectives down into 5 work streams, which complement the 4 pillars of the Right Care, Right Person. So it's around, to summarise, it's around reducing police involvement in welfare checks, most welfare checks unless there's risk of criminality or serious harm, removing police involvement in responding to incidents of missing people or walkouts from mental health facilities and critical care units, reducing Section 136 handover times, and reducing police involvement in the initial response to people in mental health crisis and transport thereof. So it's an ongoing process. It's likely to be in place for many months, and there are still some grey areas where we will, things may fall outside policy, but just referring back to that overarching principle that we're not going to knowingly let anybody come to any harm, that's kind of the fallback position. So in terms of baselining our data, there is a slide there, but it's a little bit out of date from December. Our analysts have been putting some stuff together, but that weren't able to get it to me in time. But the picture is very, very similar. So our concern for welfare and mental health incidents month on month throughout the whole of 2023 remain very, very steady. There's some seasonal increases in the summer, as one would expect. But if anybody's looking at those charts, you don't need to look at them. I can talk you through it. But basically, there's a line through the middle which shows of the calls for welfare concern that we get, how many we actually deploy to. Historically, we always deploy to about 40% of those. So 40% of those we send officers out, and the other 60% we push back either to the originating agency saying this is more appropriate for you to go and look at, or we'd refer to other agencies, or we'd make our own risk assessment and determine that it didn't matter if we didn't go, and whether the other agencies decided to go or not was a matter for them. Following the launch of Right Care, Right Person, that hasn't really changed. We're still only attending about 40%. But the interesting thing is 40% is the figure to which some of the very earliest adopters of Right Care, Right Person, in particular Humberside, managed to get their attendance rates down to and to stabilise at. So I'm not personally convinced we'll get it much lower than that. But it also goes to show that some of the other forces were massively over responding in the first place. So I'm fairly comfortable with that 40% because most of those incidents within that 40% either fall outside of the Right Care, Right Person remit because they've been called in by individuals or rather than partner agencies, or there is some element of police response required, i.e. it is an immediate concern for welfare, which means we're going to go, or there's some element of neglect or criminality or weapons involved or something of that nature which would make it inappropriate for us not to respond. That said, the interesting thing is that some of our, what we call our closing qualifiers, have shown a month-on-month reduction since it was introduced. Now, when we close an incident, we've got certain codes that we can put on there, designating it in different categories, really to enable us to look at our demand and our trends. And the number of incidents which are being closed with the right care, right person code, for want of a better word, it has shown a month-on-month decrease since it got introduced. At this stage of the monitoring, all we can say for sure is that may be attributable to seasonality, because we launched it in the height of the summer when our demand is traditionally at its greatest. We don't think there's any issues around our data quality, but equally it might also be because partners are becoming more and more aware of the right care, right person process, and they're no longer phoning incidents into us, which they know are likely to be pushed back under that policy. We've also got a business assurance process in place, which has concluded that we are complying with the policy and not putting people at risk, and that it's working as it should. So it's difficult to fully assess the impact at this stage. We're going to need to run it for at least 12 months to allow us to isolate the seasonal fluctuations and see how that progresses. So in terms of the next steps, it's only been running since July. We need to allow that to go on for a full course of a year. We're continuing to work with the core group, the community goal group, through that partnership group to close the gaps, and continuing to monitor the performance figures. The initial results look reasonable. As I say, it's never going to be a panacea, because we were already in a pretty good position, and I don't anticipate that it's going to significantly, that we're going to be able to attend significantly fewer jobs than we were before, because we were already pushing back quite hard. There are some elements under the right care, right person that are outside of our control. For example, the amount of time that we'd have to wait with mental health patients before places of safety, specifically the hospitals, agree to take responsibility for them and allow the officers to resume, and the number of patients that we have to transport in police cars rather than than handing them over to ambulance service. Because clearly we can't just stamp our foot and say we're leaving this person, or we demand an ambulance come and take them, because pragmatically it makes a lot more sense for the police to drive somebody to hospital if it's going to take 20 minutes than to stand on our principles and say, okay, the ambulance have given us an ETA of 4 hours, so we're going to sit here in a lay-by with them for 4 hours. But that's something that the core group and our partners are very much alive to, and something that's going to be worked through on a medium to long-term basis to see some improvements in that respect. Because obviously they've got their own pressures as well. They can't just wave a magic wand in order to comply with that element of it. That's pretty much my input. So I'm quite happy to take any questions. The only thing I will ask is that people don't start asking me specific questions about specific incidents, because I'm without having the full facts to hand and a good 20 minutes, half an hour to delve into them, it wouldn't be a fair position to put me in. Yeah.
Thank you very much, James. Yes, I've got Pratima first.
James, thanks for that. I've kept abreast of this, partly because of being on the IAG, and we've had kind of presentations around this, and I know it's national police, kind of national policy around this. And I guess the origins of it is because police were getting caught up in public services that they weren't responsible for, primarily mental health services. So one of the reports we received from Miriam in Wellingborough was that 40% of the people presenting in any month, I think it was, are people with mental health needs to the police and this. So I've got real concerns about this, and I'm sure you know the concerns, but what confidence do we have that the mental health services are then geared up to pick up where you leave off? And I guess because the police pick up this because you are the 24/7 service, not that it is your responsibility to pick up mental health, I think. So what confidence levels do we have that that is in place? Because in Lincolnshire, I think it was Lincolnshire, where they had a death of a person who wasn't picked up by any services, and the police had taken this approach, and the person died, and I heard that they'd reverted back to not doing this. So, yeah.
Yeah, there are some... the mental health demand is significant. I will take issue with your comment that the police are responsible for mental health. They have a role to play without a doubt, particularly where there's immediate concerns or where there's criminality involved, but they're not the prime agency and they're not equipped to deal with it in the same way that other providers are. Are there risks? Yes, there are. Clearly there are risks, and this policy is about recognising those risks and doing its utmost to mitigate them. But if there's not an immediate risk, then the police are not the most appropriate agency to deal with the long-term mental health of an individual. That said, we do have Operation Alloy, who are jointly funded by the police and NHFT, and they work for the majority of the day, for the majority of the week, assisting the police in their response to mental health, people in mental health crisis, and they work primarily in the control room with ourselves, but they also go out and about with officers, and they are worth their weight in gold. And that does bridge a lot of the gap, but at the same time, I know that the NHFT recognise that there's gaps there. So they've recently introduced the crisis car, which is a similar kind of thing. It's basically a mental health ambulance, which is available 24/7, which goes some way to picking up those gaps and that risk that you've identified.
Thank you. Kate?
Yep. Sorry, I was just going to ask about the data that you collect when you use the right place, right person, right place policy. Do you collect that in areas? So would we know how many times that had been used in Corby, for instance? And is that, again, something that could layer into sort of the CWF format? Because then we could look at, well, who is there when the right place, right person policy is used to help come around that and pick it up? Again, it's just following on, really, that I understand it, but it's then going to create a gap. And do we follow the people that have this used in that way to see where they are picked up then and how that is, just to get some case study work of actually, if I'm not going there, I'm going to go there, and then can we support those people to be able to cope with that? Yeah, just a question.
So in terms of can we break it down by area, I'm not a statistician or an analyst, but it's based on all the stats that are collated are based on the closures and the flagging of individual incidents that we have. So I've no doubt that they could do that for areas. We don't. We at the moment, we're only looking at it strategically. In terms of tracking people, were you talking about tracking people through the system who'd...
Well, yeah, I guess it's if they aren't supported through the police, where are they supported then? And is there a sort of a trial period of introducing this where you see if they don't come to you, then where do they go? Because again, on a sort of place-based model, where are people turning then? Where are they using? How are they solving some of those problems and getting some help? And again, can things be supported or funded or financed in any way to plug that or support it in a local...
Yeah, well, that's exactly what the core group is for. It's about plugging those gaps. So if for example, hospital has said, acute hospital has said somebody's walked out, then we'd be saying to them, well, in the first instance, if you look at all the national guidance, it's suggesting that the hospital are responsible for making those initial checks at their home address rather than sending the police round if there's no immediate welfare. And if they're finding that they're unable to... And that's just one example, but it's about pushing back to the agencies. Quite often, when the agencies are pushed back to, they'll then decide that the risk actually isn't so great after all. But it's it's a recognition that it's not a responsibility of the police, and it's become the default position. As I say, it's nowhere near as bad here as it has been in other parts of the country. So it's not made a huge change here, but in other parts of the country, I suspect the threshold at which the partners phone the police and ask them to do those checks will have significantly gone up.
Well, I think maybe that's something that could be looked into is the spread across the area of when the instance occurred of closure, because it would actually give the LAPS and the community wellbeing forums an idea that, well, it's all centred in a particular area, and then having a look to see if there was a follow-up that was more appropriate, or to make sure that people aren't falling through the net. Sorry. Sam.
Thank you, Chair. Thank you, James. It's stimulated some interesting debate. I just really wanted to give the board an assurance. So obviously I'm from an adult social care background. I know that James has personally been out to talk to our teams and our leaders within our teams around what this means for us and our population and the people that we work with. So there has been really, really good engagement. I think the bit that we have to acknowledge, there will be a nervousness that people potentially could fall through gaps. I don't think we've got any representation from NHFT in the room today, but actually there is the groups that sit under this that are offering that kind of strategic gap and making sure that those services are met. But it is very much about making sure that people's needs are met by the most appropriate person. And on occasions, that isn't the police. And on the occasions where it is the police, what's being said is very much they will make that response. I think there is something around, particularly into some of the areas. So what are those services? So, you said about what happens if somebody leaves Kettering General Hospital and we suspect that they're a danger to themselves. Well, Kettering General Hospital have a partnership called the Acute Mental Health Liaison Service that sits within there, that has members that are from NHFT and social care in there, that potentially would be the more appropriate people to give the response. And then the only other thing, and I've been in Northamptonshire for quite a long time, most people know that, we've been on a bit of a different journey in Northamptonshire, so I think potentially some of the responses that have been enacted by the Right Care movement were already in place here. So police potentially not conveying people, not responding to standard welfare checks, but actually asking organisations to go back and do that. I think the data will be really interesting, and I think if we can get on that on a place basis, that really helps us to look when we want to start building community assets or when any of our particular gaps are. But yeah, it was just to say that there has been, well, I certainly from my perspective feel there has been a good level of engagement, and I can certainly say from my frontline services there's been a nervousness, but actually understanding, and when we've been through what does that actually mean for our people, we're accepting that actually, yes, there are gaps in services, we know that as a system, but we don't feel that we're going to see a really different offer to the people.
Thank you, Sam. That's quite reassuring. Kate.
Just off the back of that to ask, so it's great that the adult social care teams have been briefed on it. Have you been able to do anything with the voluntary community sector around that? So I'm thinking community centres, food banks, all of that sort of thing where people may present if they're aware of this policy, then that would be really helpful. It would embed and it would probably stop maybe, I don't know, just some of the concern or panic or rumours or whatever it may be. If we were able to get some accurate information in there, that would be good.
Yeah, the initial consultation was led by a colleague of mine who is no longer with the force, but it was done at very strategic levels in order that people could cascade it down. There are so many different voluntary organisations within the county, and a bit like in the police, the turnover of staff is quite high. That we've got the press releases out, we've briefed at the high level, we've come into things like this. The awareness of it is finally getting up there. It did certainly take a few months, and as I say, it was really when the Met went live with it, even though we'd already been live for a number of months, that it sort of started coming into public consciousness. So it has raised it has raised some elements of concern amongst some members of the public and amongst some agencies. But I think once people start actually looking at what has changed in practice, people generally tend to be quite reassured. So, you know, the acute hospitals and the mental health hospitals within the area, we've already had well-established MOUs with them for a long time, which means that nothing's really changed in that respect. And as I say, a lot of the other things that are already kind of hardwired into the ways of doing things with those partner agencies. And of course, you know, go back to the first principle I said, that we'd never knowingly put anybody at serious risk, and particularly if there's you know, a reasonable assumption that they're going to come to immediate harm, then we continue to go anyway.
Yes.
Sorry, Martin Glenn from EMAS. I sit on the core group alongside James, and just one of those workshops is around communication and around how we communicate, what changes this brings, but also about those gaps and how those gaps are filled. And I think that's really important. And what's actually really important on that core group is we've got people with lived experience. And I think that helps to understand the times when the police are involved, and actually whether that's a good or a bad thing. And that's no disrespect to my police colleagues. It's just that they're not sometimes the right people for the response that these people need, whether that's ourselves, whether that's other mental health. And I think, you know, like Sam said, we haven't got an HFT here, but actually there's been a lot of work done, if you like, prior to this to underpin the needs of mental health within the community. You know, services that we can refer to, so that we don't get actually embroiled in something that potentially doesn't need a hospital conveyance, but it needs that mental health support. So this is very sort of multifactorial, which is why there's that core group with all of those strategic elements within it, to make sure that we're identifying the gaps. And what I would say is we're also, as a regional organisation, we're bringing in the lessons from other areas into this group, so that we can look at how it's been done in other areas and how that applies within Northamptonshire, so that we can learn from those.
Right. Oh, yes.
Sorry. So I suppose the ultimate risk is adverse outcome, isn't it? And I'm absolutely in favour of the right agencies being involved, but we all know that people fall through the gap. Of course, what hits the national headlines is when, and indeed the narrative is nearly always agencies didn't work together, and somebody falls through the gap and there's a tragedy, and there's an adverse outcome. Is there learning from other areas around potential where those adverse outcomes have happened that are feeding into this work? I still think the risk is quite small, in the sense that often if you push back, the agency then says, actually, the risk isn't that great, which actually tells you quite a lot. But I just wondered what, you know, because is there data being collected on, in a sense, positive and adverse outcome?
Yeah, I mean, the Home Office is collating a lot of the data nationally on the demand and things like that. In terms of any adverse outcomes, the IOPC generally, if someone died, for example, the IOPC will always, Independent Office of Police Conduct, will always look at those and examine them, and any learning that comes from those, as with any other outcome that the IOPC determine on, is shared nationally.
I have one speaker left, and then if we can move on, because we have a bit of a deadline. Thank you.
Yeah, I just wanted to share, if it's helpful, I've met with Humberside and seen what they did there, and the way it's done is the most important thing, because in Humberside what they did, there was a team of mental health professionals in the call centre, and it was you know, all partners are involved, as you're doing here. So just for reassurance, really, when this works well, it does work. Where there's been problems nationally, and I've spoken to a number of authorities that have had a few issues, is where it's single agency, which is not what I'm experiencing Northamptonshire Police do. But in some places, the force have, unfortunately, said, OK, we're not touching any of that. And then that has caused problems in the partnership. But I have to say I'm reassured with the way Northamptonshire Police are approaching this.
Thank you, Colin. Well, we're asked to note this report, so if we can do that. And then I need to move on fairly swiftly, because Chris Pallett has a deadline. Integrated Care Northamptonshire putting in place an integrated multi-partner approach to their urgent and emergency care strategy, and I'd like to call on Chris to introduce it.
Thank you, Councillor. Good afternoon, ladies and gentlemen. My name's Chris Pallow. I'm the Director of Ops and Deputy Coup at NHS Northamptonshire ICB. I've worked there for about a year, and before that I was involved in the COVID Vax programme and worked at Northampton General for many years. The only page I'm going to talk to, you'll probably be pleased to hear, is page 90 in your pack. That's where there is a summary of the 6 stages of the urgent and emergency care strategy. And the reason I'm here today is to ask for your engagement. This isn't at the final point of being approved. We're talking to a number of interested groups, and some of you around the table have been very closely involved in the evolution of this, not just in the past few months, but a large amount of the work that has gone into the approach that we're going to be taking. Within our proposed strategy are 6 pillars, and we've designed them deliberately to work up the continuum of care from the time at which someone who has already been diagnosed with a long-term condition and therefore is at higher risk of an emergency or unplanned interaction with the NHS, right through to where we've been unfortunately unable to prevent someone becoming ill, unable to prevent their admission to hospital, and we're needing to support them to get the most appropriate care in the most appropriate environment. So those 6 pillars that we're calling them are thus. The first, as I've mentioned, is that patient who has been diagnosed with a long-term condition, and there are many hundreds of thousands of them within our country. Many people living with long-term conditions that they don't actually know about, but many, especially as we live longer lives, many of us are living with 1, 2, 3 long-term conditions. That could be diabetes, it could be pulmonary disease, it could be hypertension. But we know that the likelihood is if those conditions become poorly controlled, then there is a greater likelihood of something happening, either an unplanned admission to hospital, but much more likely more appointments requested in primary care and more support from broader parts of our health community. And what I will say is this strategy isn't the traditional urgent emergency care strategy that we'll have written in the NHS. This is not just, in fact, it's actually a small part is about the blue lights and sirens and the flashing lights outside the emergency department. It's much more about trying to prevent people getting there in the first place. And if they do get there, helping them to get out quickly, because no one wants to be in hospital. So that first pillar is about supporting people at home. It's about supporting people to live longer, healthier lives, supported by public health prevention, and crucially supported by some of the groups that are already operating in many of our localities around the county, supporting diabetes, pulmonary disease, those conditions that I mentioned. And actually, they don't need to necessarily be delivered by the health service. We have many voluntary sectors partners already supporting us, and some of you may have seen about 6 to 8 weeks ago now a story on Look East where one of our patients was focused on a gentleman who lives in the Daventry area who lost his wife a couple of years ago, lost his verve for life, wasn't getting out, wasn't eating particularly healthily, did have some long-term conditions and started to deteriorate. And we supported him through a group called Pumped Up, which is a cardiac rehabilitation group. And that gentleman was talking publicly about the massive benefit that had made to his life. We are one of the only counties in the country that has so far been able to slightly reduce our over 85 admissions to hospital and to flatline some of our other admissions. We've got a long way to go. I'm not trying to say we've sorted it, but some of the groups we had in place in partnership across our counties have been really important, and that is what Pillar 1 is about. It's trying to support patients to not need the health service wherever possible. Pillar 2 is where that patient is starting to deteriorate a little, starting to need some additional support. You will all have heard in the news that our colleagues in primary care are under huge pressure. We always hear about accident and emergency, and that is accurate. We don't hear quite so much about primary care. You will all have heard, or maybe even experienced, the 9 o'clock rush to try and get an appointment, some of the difficulties to get same-day access. Some of our practices are now having to focus so much on same-day access that the ability for them to see patients with long-term conditions is compromised, not because that's what they want, but because that's where the pressure lies. We want to work with our colleagues in primary care to look at how we can make same-day access services more amenable to our population. If we can come to this point, and we haven't written this element of the strategy yet, looking at how we can have hubs around our county that can support those patients closer to their home, but freeing up our colleagues in primary care for what their expertise really is for. Pillar 3 is where those patients are starting to deteriorate a little more. And we have in place in Northamptonshire a single point of access that's led by our colleagues from NHFT, which a couple of years ago, and I've used this analogy several times, my apologies if you heard it, the S in single point of access used to stand for several. You could go to one area if you needed mental health support, one if you needed access to the health service, another if you wanted NHS 111, another if you need support from our colleagues from the local authorities. What we want to do is to make it easy for patients to receive support, and not just redirection, but active support from experts in our single point of access, such as some of our colleagues in primary care. We already work very closely with Martin's team at East Midlands Ambulance to take calls from what we call the stack, the numbers of calls which patients have called into the ambulance service and need support, which are much more appropriate for a non-blue light response, but for an urgent community response for someone who's in their home but is frail, is elderly, is worried, is frightened, and is at risk of admission. The other thing that we really want to improve within that service is support to patients at the end of their life. Many of us will have been in that situation where someone who's close to us is nearing the end of their life. There's nothing that we can do to prevent that, but we can do a lot to support the family and to ensure that those patients stay, which is usually in their home, because that's what they choose, in a safe environment whilst they live out their days. It's very easy, and I can speak from personal experience of supporting a close relative who is dying. It's very easy when it becomes frightening to ring 999. What we want to be able to do is to put support around those patients, because sadly we still see ambulances being called and patients being conveyed into accident emergency when unfortunately there's not very much that we can do, but that's the safer response. Very similar to what my police colleague was saying about mental health patients in a different environment. Again, so if we move up the care strategy again, we want to be able to support those patients who have a subacute need. So patients who need something to keep them safe. It could be a scan, it could be a diagnostic, it could be any range of things, often provided by my colleagues at Northampton at Kettering Generals through same-day emergency care. We have an awful lot of services which are starting to expand. Our community diagnostic centres provide the ability for us to access many more modalities quicker and in different parts of our county. We want to build upon those to be able to ensure that we can support patients wherever possible outside of hospital. There are always times when we don't succeed. There are always times when patients have become so ill that they either need to be admitted by their GP, they arrive themselves and are very sick, or our ambulance colleagues bring them to hospital. And when that happens, we recognise, firstly, they don't really want to be there. Secondly, we have an obligation to ensure they receive fast, appropriate care in an environment that's most appropriate to their needs. There's no secret that the NHS this winter and in prior winters has had a really difficult time. And everything that we are trying to do is ensure that our colleagues in primary care and in the acute sector are using their skills to the best of their ability and for what the patients need. And often, at the moment, we are unable to do that because of the sheer volume. If our belief is if we get the front part of this journey right, then this part of our journey will be easier. I'm not saying it will be resolved, but I'm saying it will be easier. And so we want to work very closely with our colleagues in the acute sector to support the developments in their site that are already in train and which will make a wonderful difference to patients, but also to ensure their skills are there for the most appropriate patients. Lastly, and I think probably as equally important to anything else, is supporting patients to leave hospital. Now, the vast majority, 95% of people, go home when they're discharged because they are ambulatory and they have been treated for the conditions that they went in for, and they don't need additional support when they leave. But many need something. And we have three pathways that we talk about in the NHS, Pathway 1 is where patients are able to go home but need some support. That could be some equipment. It could be some support from the district nurse. It could be some support and re-ablement from our colleagues in social care. But they are largely relatively easy to support to go home. Pathway 2 is where someone's had a more serious condition and is more frail and needs some support before they go home in a bedded facility. That could be some of our recovering independence beds. It could be some of our beds in one of our community hospitals to have some intensive rehabilitation. But the destination anticipation is to go home. And then P3 is those patients whose place of residence is likely to be long-term care because they're either so frail or they've suffered such a health impact that they unfortunately almost certainly won't go back to independent living. But for all of those pathways, we can make improvements. So if I talk about one in terms of P3, that very last pathway, patients who unfortunately have dementia or delirium often stay in hospital for a long period of time. Their behaviour is sometimes very challenging. They're very distressed themselves and they're often very distressing for their family. One of our aims of our strategy is to have a dedicated facility for these patients to try to remove them from Northampton and from Kettering and to ensure that we co-locate as much care as possible in partnership with the voluntary sector, with primary care, with NHFT, so that all of those patients receive the support that they can. We are not saying that we will always enable those patients to recover, but we are saying is we will enable them to receive their care in the most appropriate place, which is not an acute hospital ward, and to transition to their long-term care as quickly as possible. So we're hoping to publish our strategy within the next 8 weeks, and either now or, of course, afterwards, I'd welcome any comments from anyone, really. But, Councillor, that's all I'll say, and ask for any questions.
Thank you very much. So, Jane, do you want to go first?
Thank you, Chris. This is not the first time I've seen this presented. I've seen it a couple of times. I think it's really clear. I think that this particular slide describes really well that kind of continuum from where we can do that almost prevention stuff at one end to the most acute on the other end. I'm just interested in the area around primary care because obviously that's a really big issue at the moment, and we know that our colleagues in primary care are under enormous pressure in terms of appointments and also just in terms of acuity and a whole range of other things that they've seen coming through the door. Can I ask about, because I believe that there is a primary care access, the ICB is part of the 5-year plan, is that right?
So yes, it is right, and in the coming year, the aim of the ICB and my colleagues in the primary care part of the ICB is to work with our primary care clinical colleagues to design a primary care strategy that fits underneath this and addresses many of the things we're talking about. But yes, you're right. So we started that journey, but there's a long way to go, and I think you're entirely right to point to the amount of pressure that sector is on. Either if you don't have to talk to many primary care colleagues to understand that, you don't have to try hard to access the service yourself to realise it's true.
Pratima first and then Sean.
Chris, thanks. I was at the place board, so you presented there. Really good plan. I was thinking if this diagram or the strategy was a triangle, you'd have a lot more people in the self-care, active prevention pillar, if you like, because that's where, if we can make the greater impact there, clearly that mitigates demand at the top end. And I just wonder what kind of resources are being applied in that first end, and also our experience through the SNN Support Northampton Service and work with black communities. One of the key absolute issues for people here is navigation to any of these pillars and pathways. You know, it's so difficult. I was talking to somebody yesterday who's a carer for his father who's had a stroke, been in KGH, NGH, lives in London. His mother is the main carer. And just one conversation, he said to me, he sent a message saying, that was just so supportive because I have no idea how to navigate my way. And it was just a call to say, we're here, we can help you through this. And it made the biggest difference. So the real sense of that community-led, that kind of voluntary sector impact that we could have, the agility that, you know, prevention can have. Just, and also the resourcing at that level compared to the other levels.
I'm not going to lie, I don't know the I don't know the proportion of the resourcing. I can try and find out for you, but I'm just going to be completely honest. What I can absolutely hand on heart say without looking at any figures, and this isn't about finances presentation, but I completely understand where you're coming from, is that pound for pound in terms of outcomes, you don't have to spend very much on the left-hand side to get huge outcomes compared to the cost of a patient coming into hospital who has been admitted. It wouldn't even compare. With regards to navigating patients, do you know what? I'm going to be completely honest. I think we've done a jolly good job of confusing many people with the signposting or lack of it that we have. I don't mean physical signposting. I mean, do I ring 111? Do I go to pharmacy first? Do I ring my GP? Do I go to ED? Oh, do you know what? The lights are on in ED. I'll go there, and I'll probably be seen in 4 hours. I think one of the key tasks that we have is to communicate with our public in a simpler, less confusing way, irrespective of who you are, where you live, which background you're from. And I think as well, key to this is our single point of access. And it needs to be single. It really does need to be that proper S. When I was supporting my relative who was dying, I was bounced between health single point of access and social care. And all I wanted was some equipment to make her life easier. I think I'm long-windedly agreeing wholeheartedly with what you're saying.
Okay, Sean.
Thank you. Yeah, and just picking up on that, it's just reminding us all about the value that there is in the voluntary sector partners here. You know, whether it's the Ageing Well place, whether it's the SNN programme, our mental health colleagues. And the value within that, and the risks that we run, particularly with the financial pressures that the system is under. We're at tipping points with many of our service colleagues in their services being available or not. So it's just a reminder about the opportunities that we've got. Thanks.
Ali, did you want to come in?
Thank you, Chair. Thank you, Chris. I know I've heard this several times in the Place Board, and I suppose we're about to go on to the North Place Development Paper. This is cross-fertilising agenda items. So your left-hand pillar in that strategy, if you take it further left, the work of the LAPS, proactive care, prevention, sit further left, which goes back to the point of Support North Hants and how it all connects. So that early intervention of improving health and well-being right downstream, which is at the heart of our Live Your Best Life connects. So all these items all the way through today have common themes. And also, Chris, I think there is something about that intelligence from place within it that starts to come through, because there are different needs for different urgent care, the different services, the asset maps for the LAPS, all of that, which is why I know you came to the Place Board. So they join effectively in support of the strategy.
I completely agree. The work that has been going on in our localities is linked to the LAPs. I was thinking to the tobacco reduction conversation earlier on when I was sat in the corner. That is also delivered at some of those. There are so many codependencies for the work that we're doing, and actually a lot of the outcomes we're aiming for they're not similar because there's slightly different outcomes, but the population and the way that we're trying to work is very much aligned.
Thank you. Colin.
Yeah, just like to sort of add a few things to what Chris has said. As probably the only person that sort of represents GPs and primary care in the room, to answer the question about finance, at the moment we see about 90% of all patient encounters on a daily basis with less than 10% of the budget. So anything that can go forwards to actually make the system better. Us as an NMC would look to support any system that can help patients navigate the system in a way. We see something like 17,000 patients a day in primary care. So we really are at the heart of this. And as I said, as Chris will know, anything that can do to help this, we're always willing to support. But I will caveat that it needs to follow some finance, estates, digital, all these things need to be there. This is really aspirational, but unfortunately, unless it gets that dirty word money, it may not work as well as we would all like. Thank you.
Yes, well put. Yeah. Yes, Trevor. Sorry, your microphone.
Yeah, in terms of delivering this, sort of crucially, it's actually not just about putting the infrastructure, but it's, as you've said several times, it's about the communication. It's about how do we communicate this out, and key in communicating it out is when people experience that if they go to X, Y and Z in the system to the left, they'll get treatment. Otherwise, they will pitch up at the front door of either NGH or KGH or at the Corby Urgent Care Centre, quite often inappropriately. So we've got to make sure there's a big piece in here about communication, not just with the public, but actually with each component in the system, so that the receptionist at the GP surgery or somebody else knows exactly who it is that somebody needs to talk to. I, like you, have done that bit of trying to navigate as a carer for somebody through the system quite recently, and knowing the system, it's still virtually impossible. So how we do this is about communication. The second point is, if we don't do this, the bit to the right, and there's various bits in the detail of this that talks about changing infrastructure, etc., there won't necessarily be the resource to do that. So the only way we're going to be able to free up some of that resource is actually work out ways that we can convince the public by delivering the care to the left to be able to get them to attend there, because the infrastructure won't be there on the right necessarily. And the last point is, and I'm pleased to see in this, I hadn't seen it before, I don't know why I've missed it, that split on the P3s between the longer care and the end-of-life fast track. Again, having been involved in end-of-life care personally, that's vital, because the systems don't work at the moment. They're better, significantly better, but we've still got a long way to go on that.
Thank you very much. I think we can go to Sam.
Thank you. I think they're all really valid comments, aren't they? And actually what I was thinking about as I was listening to everybody's feedback was, we're really busy over here in Northamptonshire or North Northampton. There's a lot of strategy development, there's all of this, there's the place work, there's the adult social care strategy, there's the urgent emergency care strategy, and they are all aligned, and quite a significant amount of work has been put in place to make sure that we're very clear on not only where we are now, but where we want to go. And I think one of our biggest challenges is to keep that alignment. So nothing, and obviously I've been party to this, but when we look at recovery and independence, well, actually that's building those assets that create the infrastructure that people are saying to keep people away from the acutes, to return people to their own place of residence rather than to the care home industry. It's all of those. So I think when we bring all of this together, that path is very simply, I think, laid out for us. I think it's that commitment and that wider, so how do we communicate with, families and their relatives so that it feels tangibly different? And then my challenging point is then how do we hold our nerve to take that left shift into the investment in more community-led services in order to continue to build that infrastructure. Yeah. But yeah, really helpful, Chris. Thank you.
Yeah, Sheila.
Yes, that's sort of half said what I was going to say, and I say it at every meeting I've been at lately. You've got to make sure that all this new information gets to the people who are going to receive the care, and it doesn't. Chris Kenny, in fact, will know that I said this to him about his last presentation here. The policy was great, but everybody needs to know about it, and the man in the street doesn't always get the right information. The other question that I always have, because it is personal to me, is you talk about support for people with long-term conditions, and you never mention the ones that I suffer from. And I don't really know, apart from the people in the medical world that I see any support going on?
I'm not going to ask what they are here, but let's talk privately, and then I'll try and answer your question about your long-term conditions. But certainly I wouldn't do that in public, Sheila.
Yes, sorry.
Yeah, just a final point. So a couple of things. One, this is really refreshing to see, an urgent and acute, in a sense, sort of emergency strategy, which actually has all of these assets to it. It's the first time I've seen it, and I'm really impressed with it, actually. But I do take the point that if you were to say to the general public, here's the urgent and emergency strategy, they would only see subacute and emergency and acute care. That's the bit that they would be focused on. And so there is a real sort of communication piece with the general public, really, to say, actually, all of these elements are really important. And if we can get the bits on the left right, then the other bits will be that much more effective and efficient when you need them.
I think nearly all of the points are around communication and involvement. Yesterday, 550 people walked into Northampton General Hospital's ED. 550. Now, that pales into insignificance against the numbers that primary care. But the real question for me is how many of those people needed the care of an emergency department with an intensive care unit behind it, emergency theatres behind it, and the answer is probably very, very few. That's about education and support. And changing the mindset of the public isn't the remit of this strategy. It's a societal thing, but we can do our part.
Yeah, thank you very much. I think it's so vital. It's really refreshing to see this as laid out and sort of from start to finish, rather than just focusing on one aspect, say the acute. And I think it comes down to the single point of access. I think if that when that comes into play, then I think that will be hugely important. And having heard even this week somebody that went to Kettering General because they just couldn't get any care at the primary. We know the pressures, but of course it then moves that care need elsewhere, which they didn't need. So it's really good to see this, and I hope to see it actually all coming into force as soon as possible. Any other? So if we can just note that report, then thank you very much for your time. Thank you. Okay, so moving on, we have North Place Development Update, and I'd like to ask Ali to take us through it.
Thank you, Chair. Before I move into the paper, I think it's an observation from every agenda item today. We've all talked about LAPS and community wellbeing forums in place, which means I think that we are definitely considering that local nuance of what we're trying to do, and I think that probably hasn't happened in a Health and Wellbeing Board up to this point. So that's great to see. And the paper content describes the next phase of development, and it gives you an overview of what's emerging from all the LAPs currently. And I'm going to bring my CWF chair, Leads, in to just give the nuance of what's happened in the CWFs in the last round since the writing of the paper. So what the Place Development Programme is now looking at is how we step up and adapt and evolve the local area partnership function and the community wellbeing forum functions, and definite focus on not just the networking and the engagement, but focusing on the resident communication. One voice, one communication is a bit of a theme again, I think, through the whole of the board today. The chair, the community wellbeing forums, they will be having some new chairs potentially, so there's expressions of interest out for the community wellbeing forums, and we are moving away from the phrase community wellbeing forums as a descriptor of the four. We are going to be replacing that with, if we take Corby for an example, it's going to be called Corby Place-Based Partnership. That's been agreed with the forums, has gone through the Place Board. And I suppose we want to move on from the legacy of the old forums, and we now want to change the function and really get that grip, which is a little bit of what Kate's been bringing into the room today. The lab acid maps are now completely live, and playing to James Willis's presentation from the police, there is something about that really early intervention around that health and well-being, and the signposting, the PCSOs out there, how they, you know, his police leads are saying, well, we don't know what's out there, so they're using the lab acid maps in their area to be able to really help some of those, you know, the individuals who just need some, I suppose, low-level intervention rather than the top end by the time they get to the acute hospital. So what I'm trying to do is just bring to life the place work as a foundation for at the heart of prevention and proactive care across all the themes that have come through today. So the other two important points in the paper, I'm going to move on to Support Northants next. So we've heard many a time the journey where we've had this voluntary sector collaboration, that early coordinated care, early intervention, proactive care. We've come to a bit of a tipping point with this service. We still haven't identified complete partnership funding agreements for this service. And we've only got a handful of months left. We've had conversations with ICB, with police partners and with housing associations. We still haven't formally agreed that. So I suppose, Chair, I'm highlighting it as a risk because we keep talking about prevention. We keep talking about preventative care. It's at the heart of our strategies. So we need to now do, Sam, a little bit of what you've talked about, which is that left shift, and we need to start to be committing to these services. So I do think we needed a conversation about that today and about next steps and a commitment as partners and a system that we invest in some of these early intervention models. The final point of the paper is the proactive care proposal in Appendix B. So we've got various emerging proactive care preventative models. So we've got social prescribing, spring social prescribing, we've got Support Northants, we've got the primary care link workers, social prescribing. All of these models have been commissioned separately over the past few years. They've all been delivering that preventative focus for individuals to make sure that we don't hit the statutory services and we keep people maintained in their own homes as well as they can be. And what we're proposing is that we develop a transformation programme for Northamptonshire. So we bring and have a look and evaluate all these models and think about what we want for the future to really embed this at the heart of Live Your Best Life. So that's a recommendation within the paper. I'll just turn to the Community Wellbeing Forum chairs to see, since the meetings, whether there is anything from a local perspective, and I can see silhouettes across the room, so I can just about see where you are. So please do add that local nuance, which is what we've said as a Health and Wellbeing Board is really important to bring into the room.
So, Kate.
Yeah, I can make a start. Certainly in terms of Corby, transport has been a high priority, also cost of living and low-level mental health. So they are the three key priorities that the lab and the CWF have taken feedback on from the lab. But I think it's crucial, the points that I've sort of tried to raise earlier, that we try and link in the more strategic conversations into those places. So, you know, the tobacco strategy, the vaping and smoking, all of that side of things with young people, the work around what the police have been, all of those things are things that could come with that local intelligence to the Community Wellbeing Forum and then either be rippled through or, you know, all of that. I think we need a bit more to get our teeth into in that way as a wellbeing forum or as a place-based partnership, and see those strategic connections in those places. But yeah, it is going very well, and the forum, the feedback and the dialogue and conversations, and also the work to try and build in the maturity matrix as well. So that's sort of a template for us to look as a group of organisations at where we are now and where we want to get to try and build an action plan around working together more, listening to communities more, all of that side of things. So yeah, we've brought that tool in to try and measure how we're getting on. So yeah, there's a lot going on.
Okay, so Wellingborough? Yeah.
I'll go next and Jess can come in. Just I won't repeat everything Kate has said, but just to say the the potential of what we wanted to, by the name change, we wanted to give the place-based kind of partnership some real gravitas, because we some of us knew local area partnerships and that real one place to go to where all partners come together and make kind of key strategic decisions, but more importantly work jointly together. So it's not a name change just for the sake of it. There's a real purpose to it, and I think partners really appreciated that. So the potential there, as Kate has said, in terms of bringing the different strategies to the local level and getting partners to jointly work on those is really significant. We are continually kind of saying we need senior representation and people who can make kind of key local decisions and join things up, going back into their organizations. So we would really kind of welcome that. And also just to say, as chairs, we feel really passionately about our local area, and we want to build on that passion, because we're not just there as kind of, individuals chairing meetings. We really care about the areas that we live in, and we want to see real, tangible, practical change. And that's the potential, I think, of that local kind of partnership. And also we want to make sure that we can kind of have priorities come top down from yourselves to the partnership, and then bottom up through the local area partnerships as well. So thanks.
Thank you. Yes, Sean.
If I just pick up, and so I'm here for Joe Moore, who's chair of the Kettering place-based partnership, as it is now. And just to add that if we were here to do that focused conversation around Kettering, and Corby and Wellingborough and East Northants, we'd be here till well into the dark hours, wouldn't we? So we do have real passion to have those conversations in locality, which is again where services are. And if we have that serious conversation around smoking in Corby, then there's other partners who would come round this table to help deliver and make that a reality. But great stuff going on in Kettering, by the way, and also within the smaller towns. So when we talk about place-based in Kettering, it's also Rothwell and Desborough and our rural communities as well, and we can make that happen together. Thanks.
Thank you very much. Yes.
Hiya, I'm Jess Slater for East Northants Place-Based Partnership, as we call it now. So the main themes we've been talking about in East Northants Place-Based Partnership is around community transport again, and transport in general. It seems to be echoing through Northants, the transport conversation, and there's been some extra work and a community transport forum been set up around that to work around the more granular data and concerns around community transport. So there's some promising work going on, although it seems to be a little bit slow progress at the moment. There is the commitment from the sector and from other community operators to get it working and fixed and providing that service across the community. With East Northants are starting to touch on families and low-level mental health in East Northants as well as another priority through the LAP, but that is just the beginning at the moment, because transport has been such a big issue across the whole of the north and Corby and East Northants particularly, because it's predominantly rural. It's huge. From a place-based partnership perspective, the feedback we've had from members at the Community Wellbeing Forum Place-Based Partnership is the connection with the Health and Wellbeing Board, making sure there's a two-way conversation going there, making sure we're reporting back correctly and feedback coming back through down to the partnership as well. We did put this on our review paper. It was quite a detailed review paper we did around the Community Wellbeing Forums as end of year 1 assessment. It's quite detailed, so if we need to forward that on, just please let me know.
Okay, thank you very much. So do you open that to the floor? Anyone want to come back on that? I think we obviously acknowledge the huge amount of work going on in the LAPS and community wellbeing forums. As Sean said, we could be here till midnight if we go into all the details, but I think there's a couple of the other things we need to focus on, like the Support Northants and the social prescribing.
Thank you, Chair. And I think my concerns are around that preventative focus and around there are huge pressures across the entire system financially. There is no doubt about that. You know, we live and breathe that every day. But it concerns me that if we don't make some move towards that left shift, we're never going to resolve some of the other issues. And I understand it's difficult. So from a Support North Northants perspective, the local authority have put in some funding to try and support that going forward, and also have put in an offer to independently evaluate that programme, because everything we do, we should be evaluating to make sure we're getting best value from all of the things we're investing in. And it worries me that we're in a position that we're not able to make that decision about that yet, particularly when it's where we are in the financial year, and also how much longer we've got really to do that. So that's my first concern. The other thing I just wanted to raise is I think that all the work that's going on around what does proactive care look like in North Northants is really helpful. We've got lots of different services that are being commissioned and funded in lots of different ways, all doing really excellent work to support people, particularly if we think about Chris's work, trying to keep them that further down in terms of the pillars of urgent care. And we do need a really good strategic plan for how we both develop that into a really strong single model going forward, and how we then fund that on a sustainable basis. So they were just the comments, really, Chair, that I wanted to make.
Fatima.
Can I just follow up from Jane on the Support North Northants service? So we are some of the lead partners for that service, and it was really our kind of contribution, if you like, to the ICS transformation plans from a voluntary sector perspective. So the model is really kind of community-led. It's galvanizes in a significant way the coordination of all the agencies. And when we launched in June, the real launch really was from September. So we've only, in real terms, we've had 7 months of kind of work through that service. And we really couldn't have, if we'd set out the kind of targets of how many partners would be involved at this stage of the program, we probably would have said about 50, maybe that would have been stretching it. We've got 112 partners supporting support plans, because we're coordinating the very assets that are in our communities and in the voluntary sector, the private sector and the statutory sector. And so if we can work to using the existing resources in a significant way, it significantly will reduce demand on health and social care. So, and again, our targets for that service were around 200 when we started for the investment that we had. We've supported nearly 400 people, and the demand for the service is so high because it is a pathway. It has become almost integral to social care that they refer to us. So we've supported 230 people in adult social care. And other services are referring in, including self-referrals. So again, picking up from what Chris was saying, to know a service locally and to be able to access it is really important. And that navigation and that coordination is actually really kind of what people have needed. And it's probably one of a key service where all stakeholders, including service users, communities, statutory partners, voluntary partners, housing associations, police, EMAS, everybody's saying it's what's kind of needed. So in a short space of time, I think, and we've been highly evidence-based as well. So, if we were fortunate enough to have the continued funding, the independent evaluation can kick in really quite quickly into kind of what's working and what we can improve on even over the next year, and then link, as Ali's saying, around the wider proactive care model. And I think that's a major opportunity now to really kind of shape prevention and a tangible face of prevention if we are really kind of committed to transformation at this level. Thanks, Jill.
Having read some of the papers, not just these ones, but others, where it actually goes into some of the detail, and hearing about the amount of help that Support Northants have been able to give to people to stop them going into the mainstream adult social care or into hospital, and that prevention is just it's worth its weight in gold, I think. So you know, we really are hoping that we can get the funding for the second year for that. So have I got anyone else wanting to? Yes, Ali.
So just to follow up on that, we all talk in rooms, don't we, about prevention and everything that's been said today. So I'm just wondering whether, is there anything else we can do as a Health and Wellbeing Board to make sure, because this decision has been bubbling along for quite a long time, and it's not fair on the staff, and it's like lots of services, we're either going, we've got to be clear. So I'm just wondering, listening to that maybe we could maybe write from today to the services who are looking, to the organisations who are looking to fund this, to say, look, we know, as Jane said, the financial pressures, but, you know, as a Health and Wellbeing Board, it's integral to what we do. So, you know, we are just supporting. I'm just wondering whether that might help, possibly, because otherwise we'll all walk away today, and we won't actually have maybe done everything we could to try and, because not everybody's here today around the table.
Yes, I think that's one of the problems, is that
collaborative way, maybe.
Yeah, the agencies that we need to, that, you know, are being talked to at the moment, unfortunately aren't here today. So I think if we as a board, if we write to those agencies and explain the pressures and the time frame, etc., I think it would be a good move. If everyone happy that we do that. Okay.
It's visibility, isn't it? And it's in addition.
Hi, I'm here actually on behalf of Johnny Bugg from the Police EC's office. So we are represented here today, and I know there's been some conversations around this particular model, and I think the conversations were with Paul Fell, one of the directors. So we're keen to explore it. We just need some more detailed business case in order to understand what the outcomes might be in terms of our police and crime plan and how they relate. I know obviously fire and police are involved, but I think we need to continue dialogue. So I think we were expecting potentially a conversation about, is there a joint business case going to be developed here for investment for partners through the Health and Wellbeing Board, and that's part of the conversations I wanted to come and have today, is that we're keen to explore it, but we just need a little bit more detail from you in relation to how that will work. Thank you.
Are you able to help with that then, Ali, the business case?
Absolutely, and so we have been sharing. So I think time is of the essence here. So we do have some time, as Jane said, there's a little bit more investment to allow us to do that, but we need to put a limit on that effectively. So we need to do it at pace, I think, and absolutely the case for change is there with the detail. And I think there's a lot of information when it's quite new to you, so it's very difficult to work your way through it. So we need to continue that, but as long as there's a commitment to do that, then we will.
Yeah, Jane.
And then just to finalise, because I was just trying to make sure we've got the James.
I was just going to come back on that comment, if that's okay, just really quickly. I think you raise a really important point actually, and one of the things that we need to do over this next period is to look at what the impact of things like SNN are on different parts of the system. So I know that what I've seen, and I've talked to Pratima about this, initially there was a really big focus on what does it do for adult social care. Well, actually, we should also be saying, what does it do from a crime perspective, what does it do from a primary care perspective, from an urgent care perspective. And I've done work like this before in another area, and actually a lot of the benefits that you see are in parts of the system, particularly in criminal justice, but you also get enormous impact on the emergency department. So we just need to be able to quantify that. My concern is the time we've got to quantify that. We've got the resource to do it, because I've got an evaluation and research officer who is willing to do it, but I need them to have enough data to do a robust evaluation on.
Okay, Amy.
Yes, so completely support that, Jane. So I think if we can all commit to do this at pace then, over certainly the next month, max, I would say, but it would be good if we can get some endorsement from the Health and Wellbeing Board as well.
Yeah.
Great.
Yeah.
And then just to wrap that up, so the second ask in this paper is that there is a transformation programme for all those separate proactive care models. So we start to look and bring that together and take time to evaluate that and make sure that we're in that preventative space. So I just want to check back. Any views, comments on that?
I've got Kate as well.
It was just on the previous point, Ali, just to be quite prescriptive about the who is going to come together to have that conversation about the funding. You know, the Office of the Police and Crime Commissioner, but who else is it? Because the ICB aren't represented here today either, and I know they're a key conversation. So just to try to keep that level of detail of who's going to be invited, when's the meeting going to be, and how can we just really give that focused support for that conversation.
So we've got groups and we've got engagement and conversations, and what's happening is all the partners are coming together and they're going back into their organisation through the governance to get decisions made. So we're coming together, going back in and then back out again, and that's the pace of the change that we need to inject.
So how can this meeting today work with that? What's the route into that then? So if you're writing a letter or making a request, where will that land?
So I think it needs to go to the representatives who are not here today,
Yeah.
because we haven't got all sectors. It's got to go in at the right level to support the people who are coming together, Kate. So I think we've got a methodology, but it's good to get. But it's a good question, because we keep bumping these things around.
Well, I think it's time to get to the detail, isn't it, really, of the who and the how, and put some deadlines and times to it. Because if not now, then why? We can't make a decision.
And that's where we can draft something from here to make sure we've got the clarity of those timelines for everybody to work to.
Yeah.
Yes, I've been in communication with Ali and saying we need to move this on at pace, you know, and get some decisions on this. So if everyone's happy with that, we will pursue that outside this meeting as well. Okay. And the next item is the Better Care Fund update. I believe, Sam, you're going to tell us about that.
Okay, good afternoon. Last item on the agenda. And I know we're close to time, so I'm going to make it quite succinct. I've got two things that I want to talk to you. One is my usual, so everybody knows every Health and Wellbeing Board, Sam comes and she does a performance update on the Better Care Fund, and we go over those metrics. And we've had a couple of conversations around those metrics. That all sounds great, but in reality, what does that mean? So you hit 90%, but 90% of what? So I have done a really short presentation, which, you know, you'll have it in your packs. I will run through it because I think it really does just bring to life what the Better Care Fund is about and some of the ways in which we use it to make a difference. So I'll do the it's Q3 performance update, which I know is behind, but that's just the way that the reporting cycle for the Better Care Fund falls. So as I've kind of laid out for people, the Better Care Fund was a 2-year plan this year, so I brought the narrative plan and I brought the planning template, which showed the income that we had, the planned expenditure schemes, and then most importantly the metrics in which we were required to report back to the Health and Wellbeing Board. So the crux of the Better Care Fund, to enable people to stay well, safe and independent at home for longer, and to provide people with the right care in the right place at the right time. And the way that they measure us and our performance about that is by our rate of avoidable admissions to hospital, by the rate of people that are discharged to their usual place of residence, the amount of people who are being admitted due to falls, permanent admissions to residential and nursing care, and the effectiveness of reablement interventions that we offer. So I'll just canter through the metrics as they stand for Q3. So we are on track to meet our target for unplanned avoidable admissions. We've got a number of schemes that continue to run in the community, supporting people with long-term conditions such as the Pumped Up group in Kettering and Corby, remote monitoring in care homes, and that seems to be having the anticipated impact that we were looking for. Just moving through to the next metric, which is people discharged who are over the age of 65 to their usual place of residence. So just meaning that they came in from their own home in the community, that they've returned to their own home, but if they were residing in a care home, that they've returned to that type of setting. We'd set ourselves a plan of 94% of people. We're actually standing at about 95.5% of people returning to their usual place of residence, which is positive and above our planned, or where we thought we'd be landing at this time of year. Emergency admissions due to falls, again, this is on target. So recently the teams have rolled out some raised chairs, which actually enables us to work with partners to respond to people who have fallen over within their own home or care homes. They're non-injurious, they've been checked over, but actually they need a reablement response to lift those people on the floor so that they're not subject to long lengths of time on the floor, which could actually lead to them requiring an admission or at least a conveyance to hospital. So again, that's really positive that we're on track with that particular metric. This is one of my favourite metrics, if you can have a favourite metric. So this one is around the permanent admissions to residential and nursing and care homes. Now, you may remember, if you've been coming to board as long as I have, that we were a little bit of an outlier on this metric, and it just didn't feel right with all of the work that we were doing around, increasing people's reablement. So we've done a real deep dive. We've also had some really targeted activities. So I'll talk about Thackley Green in a moment. We're doing really quite well on this metric. So actually we'd forecast that we would have about 564 admissions into residential or nursing care. And as it stands at the end of Q3, we're on about 311. So that puts us well on target. I think we're going to come in below target, which actually, so the least people, the better. And that just shows that actually that is having an impact, and that is keeping people well around in their own homes for longer. So really waiting to see what that one looks like at year end, but a really positive trajectory to say that some of the work streams that we've got in place are absolutely having the desired impact. The last one is around the effectiveness of reablement. So actually, if we look at people who primarily have come out of an acute hospital, have an episode of reablement, how many of those people are in their own homes or back to their usual place of residence 91 days after that episode? And again, really positive. So we had a plan to aim for about 87.4% of people to still be at home, and we're currently at 90%. So it's really positive. We saw a little bit of a dip in that metric over the summer months. We do think we were under some significant pressure. We think that was the level of acuity, but we're right back up there to meet our plan on that one. I'm obliged to bring the report to you to give you an update on the quarterly performance. So if the board's happy to note the performance at that point, would you like me to pause to take any questions before I just pop through the short presentation I've got on reablement?
Any questions from anyone? I'd like to just say that the Razor Chairs department have been put forward for an award. So congratulations on that. Do carry on, I think.
It's really positive. Yeah, it really is positive.
Yeah. Oh, sorry, Jess.
More a comment than a question, but just to let you know, there are community providers that do domiciliary home care with Razor Chairs as well. So if you need to lean on them, I know Serve have elk lifting cushions that we lift people off the floor. So if it becomes, if you want that connection there, I'll put you in touch.
Yeah, that's really positive, because there is a pilot between ourselves, EMAS, and HFT at the moment that's looking at the use of those. So I guess as that progresses, we'll absolutely be looking to engage further. It's up to you whether you put it on the screen. I'm happy to talk through it. It's in people's packs.
Apparently we've got a problem with the screen. Which
Oh,
is
okay. I will canter through it then. So, not all reablement is equal. So when we talk about reablement, I'm going to talk about the reablement that we as a local authority provide. And there's four kind of key bits that I wanted to walk through. So one is home-based reablement. So our in-house reablement service, circa of about just over 100, maybe 150 people, primarily responding to acute discharge, but also focusing a little bit of that capacity at the community market. I don't know if anybody's heard of Professor John Bolton, it might just be me, but I listened to a speech by Professor John Bolton once, and he said, if you're going to throw anything at something, throw it at reablement. And that's something that really resonates with me, because it's proactive care that gets people back to independence. The next part I want to talk about is admission avoidance. So actually, we've talked a lot about getting people out of hospital, and there's rightfully been those calls to say, well, how do we stop people going in? So just want to talk about a little bit of the work that we do around admission avoidance. Tavida is our reablement partner. So what we realised is we have grown our reablement service, but we still didn't have enough, and we wanted to invest in giving more people the opportunity, and Tavida are the people that partner with us to do that. And then we've got our bed-based reablement. So if you can't go home, how do we give you a second opportunity to get home before considering moving you to a longer-term care placement? And we're fortunate enough to have brought Fackley Green on place. So I just was going to give you a little overview of the metrics on those. So, reablement service, because I have been asked here before, so we talk about 90%. So this year so far, year to date, we have received 1,483 referrals into our reablement service. So we're not talking insurmountable figures of people. So that's an average of about 148 a month. And actually, during January, we had a bit of a bumper month in reablement, and we had 168 referrals into our own in-house reablement service. We're forecasting that we'll get about 1,800 referrals in total this financial year. 90% of those will come from acute backdoor discharge, or as Chris referred to it, pathway 1, and about 10% come from our community demand, so keeping people at home and in the community. My personal aspiration is that we really would love to be able to increase that community response. It's just having the ability to increase our reablement service to match that demand. From a referral point of view, about 79% of our referrals into reablement are accepted. About just under 20% of them are cancelled. So either people aren't medically fit or they decline the service, and we recycle that capacity so we don't lose that. Very, very small amount of people, when somebody's sent to reablement, where reablement say they can't help, sit in about 0.5%. Really quick, it's all in the pack, so I'm not going to labour on it too much, but just to talk about some of the outcomes. So what happens when people come into reablement? What happens at the end of their journey? So actually just under 65% of those people leave the reablement service independent. So actually that's so far, or at the time I cut the data, it was just under 800 people this year, so quite a significant amount of people. About 17% of people get readmitted back into hospital, and about 13% move on to have some form of care in their own home. So that's our reablement service. Admission avoidance. So admission avoidance is for those people who are at risk of being admitted within the next 24 hours, and it links very much to the urgent care standards. So I think many people have heard of the Rapid Response Service that has a target to respond within 2 hours to avoid admissions. Well, there's an element of that that says, and actually you need to be able to provide a reablement response within 2 days. So admission avoidance, we've had 279 referrals to date. And again, 84 of those have been accepted, and about 15% of those get cancelled, which unfortunately is usually when somebody gets admitted. But again, the outcomes that we get from those episodes is about 63% of those people then go home and continue to be independent, and about 16% get admitted, and a further 16% move on to an independent provider to have some low-level interventions. But without something like the admission avoidance, without the rapid response service, those people would be subject to admissions into acute hospitals, potentially long lengths of stay, and we know then the chance of somebody coming out with less independence is far greater the longer that you stay within that environment when you don't need to be there. This really colourful slide that's in your pack is a little bit hard to read, but Tavida, our reablement partner, we took this in place because reablement, our in-house reablement service, take people that they feel they've got the best opportunity for reabling, and there were other people that might be the assistance of 2 carers, already had a small package of care, and we felt those people were missing out on the opportunity to have a reablement intervention. So Tavida was the company that we used our social care discharge grants and some money that we were given for winter to invest, to say, actually, let's give these people a second opportunity to be independent. And what we did see was actually 25% of the people who went through the service had a reduced level of need at the end, and actually 9% went from having double carers, so 2 carers attending to their care needs, to having only 1 carer. So much better for the individual, much more dignified, reduces some capacity into the care market, but ultimately is also a more cost-effective outcome for the local authority. What's really interesting about Tavida is People really love it, and when there's a couple of the comments from families and people who have been through the service, and it's really heartening to see that it's not only the physical impact and the move to independence, but the impact that that's had on those individuals themselves. The last one I'm going to talk about is Thackley Green. So I think we've talked about Thackley Green a little bit here. So we in Northants brought Thackley Green back into our ownership on July the 1st last year. And Thackley Green is a 51-bedded reablement centre. And when we took it back from West Northamptonshire, there was about 25 beds that were able to be utilised. And we worked quite quickly to upscale that to 35 operational beds within Thackley Green that just enabled us to give more people the opportunity to go to a bed base where we're able to wrap around not only reablement but occupational therapy, physiotherapy, our adult social care teams, in order to give people the best opportunity to have that proactive journey to independence and recovery before returning home. And actually, most recently, and in response to some of the system winter pressures, we've taken the beds from the 35 that we had and scaled that really rapidly up to 51 beds operational for the discharge and the reablement of those people. And again, we're getting some really good outcomes for people. So year to date, we've taken 297 people through Thackley Green, so since we took it over. That's an average of 30 people a month moving through. And actually in January, because we did facilitate the opening of the additional beds, we actually facilitated 47 admissions into Thackley Green during January, which did help to ease some of those pressures that we've heard about. About 90% of all referrals into Thackley Green result in admission, and about 9% are cancelled due to people not being medically fit, and only 0.7 are rejected. And I just want, you probably can't see it very well, but I'm going to hold it up anyway. So of this graph, what you can see is where we started having an admission and then all the way up. So what you can see is the number of people that are getting the opportunity to go to Thackley Green incrementally has increased month on month throughout the year, which is a really positive trend, and obviously getting more people through that service. So just going to talk you through some of the timescales. So the time from referral to admission is about 2 days. Which is really positive compared to some people waiting to go to Pathway 2-3 could be waiting up to 15 days for alternative provision. And then the outcomes for those people. So if you go to Thackley Green, there's an opportunity that about just under 40% of people return to full independence. And about 14% of people return home with some level of support, and about 7% of people go on to permanent residential care. There is a slightly high readmission rate into Thackley Green, as in people who go into Thackley Green that get admitted back into hospital, and we're currently working really closely with system partners to understand why do we see that? Is that around the level of acuity for people? Or actually, because Thackley Green is a residential home, we don't have nursing support in there. Are there other things that we could wrap around Thackley Green that are going to enable us to reduce that level of readmission? So we've got a little bit of a work stream. I did pop a placeholder here that says stories of difference. I didn't then attach any stories of difference, so I will make a promise to share those with the board, and people can then read them at their own leisure. But I just thought it might be really nice to actually hear what people say about the service and the difference it's made to them. And that's it for me, but I have taken us over time, so my apologies, but I'm happy to take questions.
Got Sheila then.
Yeah, if I can ask a quick question. It's simply because I was at a meeting, the ICAM People Advisory Group the other day, and Giles West was updating us on things that were happening, and I asked specifically about Spinneyfields, because it was similar to Thackley Green in the past. I remember, other people probably remember too. But he told me that it's going to be used to give some dementia services, but they would also be able to do some re-enablement?
Yes, so there's a key priority work stream across the system that is a Pathway 2 work stream, and it's very much looking at what are some of our big system gaps, and Chris alluded to it earlier. So currently dementia and delirium is a real gap for Northamptonshire. It's not only the provision for them, but the ability to wrap around the memory support services and the appropriate diagnostics to get people the right support. So that Pathway 2 is very much looking at what is the potential opportunity, because we don't need 51 dementia and delirium beds, but is it that we want to grow facilities such as Thackley to be able to have more re-ablement, enablement, but do that in a partnership between North West and HFT. So that is that work stream.
I know they've done some alterations so that they've actually got 4 beds in an area that could be better supervised for dementia patients. And it all sounds very positive again.
In fact, in Chris Pallett's slide pack, it does mention about a business case for Spinningfields. I picked that up because that's in my ward. So I'm very watching that closely. Any questions? Patrina.
Just one point. I've said this before, I know, Sam, about the potential for the Better Care Fund, and particularly I know you plan for the winter pressures every year with health as well, and the potential for that to kind of do innovation or prevention in a significant. I know Tirida and others, you'd claim that as kind of prevention. I just feel that the demand for this service is so high, and the people who get through to the service would have to be at a pretty high level of threshold to then access that service. And surely the demand is higher than obviously what you can meet. But I just feel the Better Care Fund, could do something different.
Yeah, so absolutely agree. So this year's Better Care Fund was a 2-year plan, and there we get our generic Better Care Fund, which absolutely, I think there are opportunities that we need to look at how we use that and badge that. And then we get things like the social care discharge element, which comes with grant conditions that we have to use it for specific things. So yes, do agree it's an opportunity. Some of that is tied into a 2-year plan. But yes, there are conversations, but there is no threshold for re-ablement. If re-ablement is going to enable you to be independent, there's no assessment to get into re-ablement. If you're suitable for re-ablement, you go. The only thing, like I said, is the vast majority, at 90%, goes to discharge, and my aspiration is to give everybody the opportunity to be re-able, to have true re-ablement before going on to a long-term care package.
So really, it's very much on the same topic as we saw with Chris Pallett's of, trying to help with the overall system of keeping people out of long-term care and getting them back to their home and looking after them in the right place. So thank you very much, Sam. That's very, very interesting. And any other questions from anyone? Okay. Don't think so. Thank you very much indeed. And I think with that, that's the end of the agenda. Oh, sorry, we do.
Sorry, it's just one AOB which people don't. It's literally 2 seconds. So we, as a board, were able to ask for additional members to be added to the board, and we would like to nominate Chris Holmes from Sport Northamptonshire to join the board, particularly to help us with the keeping active element of the work that we're doing. So we'd like to ask Chair for permission for Chris to be co-opted onto the board.
Yeah, so is everyone happy with that? I know Sport Northamptonshire are doing a lot of very good work to help with keeping people active, etc. Yeah, okay. Thank you very much indeed, and thank you for your attendance and engagement today. Thank you.